Okay, so yesterday, in the last lecture, we have discussed about the hypothalamus, the different nuclei hypothalamus has, right? We have discussed about all the centers from where the hypothalamus receives the inputs, right? The OVLT, we have discussed these are the circumventricular organs, that means they're devoid of blood-brain barrier, right? The area postrema, the OVLTs, right? And different functions hypothalamus performs, like the thrust and water balance by releasing the ADH, adenohypophysis. It controls adenohypophysis and pituitary, right? It contain it controls the posterior pituitary also, right? And like this neurohypophysis, right? It controls the hunger, the ANS, temperature, sexual drives, and other things. You have later nucleus, and damage to that nucleus can lead to the lean mass. That means it controls your hunger. The ventromedial nucleus controls the satiety. A damage to that area can make you very massive. Anterior nucleus it will decrease your your temperature. The posterior nucleus will increase your body temperature. Okay. Suprachiasmatic nucleus will control the circadian rhythm, which is responsible for a sleep-wake cycle. Supraoptic paraventricular nucleus, it will releases the ADH and the oxytocin, right? So it will control the labors as well as the water and your osmolarity of the body, right? You have the preoptic nucleus, and it performs two functions. One is a thermoregulation, just like the anterior and the posterior nucleus, and second is the sexual behaviors. It also releases the GnRH. Okay, a loss of GnRH releasing these neurons can lead to the Coleman syndrome. We have discussed that you will have the hypogonadism along with anosmia, right? And a damage to thermoregulation centers can lead to either the hypothermia or the hyperthermia. Now let's discuss how this anterior nucleus and the posterior nucleus controls our body temperature. Suppose your temperature is not decreasing, okay? That means you're having this hypothermia, right? And whenever you have the hypothermia, okay, what center will get activate? Anterior, posterior?
Posterior.
Okay, good. Okay, so whenever the temperature is dropping, okay, this posterior this nucleus can get activate, right? And after activating, it does two, three things. One is the activation of the sympathetic nervous system, right? As you can see, it controls the sympathetic nervous system. And by activating sympathetic nervous system, you're having a peripheral vasoconstriction. And as a result, blood to the peripheral areas in your body, like the limbs, will be decreased. And as a result, the heat loss will be decreased, right? Second is increasing the muscular tone. And as a result, you will have the shivering, okay? And that controls the body heat. Okay, you also have some brown fat. Okay, metabolism of this brown fat occurs so that you can release more heat. Okay, you also have this thyroid hormone. Okay, so thyroid hormone function will be increased. And you guys know, whenever you have a hyperthyroidism or whenever you have a high thyroid hormone levels, you will get the heat, right? So your BMR will increase. Okay, and all these actions will lead to a decrease in the heat loss and increase in the metabolic rate. Okay, so ultimately you're doing two things. One is decreasing the heat loss, and second is the increasing metabolic rate. The metabolic rate will be increased by increasing thyroid hormone, okay, as well as this brown fat metabolism, okay, and the heat loss will be prevented by the shivering, by muscle tone, by sympathetic hyperactivity, right? Now, whenever you have this hypothermia, okay, and the peripheral vasoconstriction occur. But you guys know that in the major vessels of your body, you have these beta receptors, right? Not the alpha receptors. Only in the periphery, you are having alpha receptors, right?
Yes.
So whenever you have the activation of the sympathetic nervous system, the peripheral vasoconstriction occur, okay, and all the blood will be pulled down in the central organs of the body, like the brain, like the liver, like the kidney, right? Like the GI system, okay?
Yes.
And in your heart also, right? So what happens whenever you have the central pooling of the blood? The stretch receptors in the iotid and the carotid bodies, they will get activated. Okay, are you getting my
Yeah.
point? So ultimately, and this will trick your body that you're having too much volume of water, and as a result, the compensatory mechanisms can get activated, and they will decreases the ADH first. because you're having a central volume will be very much high. So ultimately the ADS will be increased. Sorry, this ADS will be decreased. Okay, and as a result, you're having an increased urine output, and that's why whenever you have cold, you will get the increased micturition, right? And that's because of fall in ADS levels. Is that okay?
Yeah.
Now, second, because of a central volume increased, you will have the myocardial stretch. Go forward. Yeah. Because of the increase in the volume, you will have the increase in myocardial stretch. And you guys know, whenever the this muscle stretch occur, you will have a release of this ANP and BNP. Okay, so their level will be increased. Because of too much volume, the baroreceptor stretch will occur, and as a result, the firing of these baroreceptors will occur. Okay, you will have a peripheral vasoconstriction, and because of that, you will have an increase in the capillary refill time. We have discussed that in the CVS section already. Whenever you have a decreased blood supply to the periphery, you can have a increase in the capillary fill time. Okay, and because of the sympathetic activation, you will have an increase in the stress hormone, and whenever the stress hormone increases, like the cortisol, you will have a high blood glucose also, right? So all these findings will be there whenever you have a central hypovolemia, and that happens whenever you got the hypothermia or whenever you expose yourself in the cold. Is that okay?
Yeah.
Any doubt?
No, thank you.
Okay, now what happens when you got the hyperthermia? Now, because of the hyperthermia, the adaptations will be opposite. You will get a peripheral vasodilation so that the blood supply in the periphery can increase, and you will get an increase in the heat loss. You will get a diphoriasis, that means a sweating, and that's because of increase in the parasympathetic activity. You will have a decrease in the thyroid hormone so that your BMI will be decreased, metabolism will be decreased, and you get the cold temperature. Okay, and that's why whenever there is a very heat outside, your body gets cold. Okay, and that's because of this sweating and all these things, right? So yeah, I think that would be it. Okay, so that's about the hypothalamus. Any doubts so far? Please ask.
Could you please list down the points again for what happens in hyperthermia? Like what all things happen basically?
See, just opposite to the hypothermia, you're having a peripheral vasodilation so that the heat loss can be there. Okay, you will get diphoriasis, that means the sweating, so that the body can go in this cold thing, right? You will have a decrease in the thyroid hormone, right? So that the BMI the BMR will be decreased. Okay, and the heat will be decreased. Okay, so ultimately you're having an increased heat loss and you're having a decrease in the metabolic rate in case of hyperthermia. Okay,
Okay, I got it.
just opposite to what happened in the hypothermia. Okay, now you have the thalamus. And please note that every input you're receiving from the periphery, all sensory inputs or all these proprioception inputs, okay, they will travel all the way to your spinal cord, and then they reach the thalamus. And from thalamus, they will go to the respective areas in the brain. Okay, so you have certain nucleuses, okay, and they will transfer all these impulses to their respective areas in the brain, right? First, you have the ventral posterior lateral area, the ventral posterior lateral nucleus. Okay, it receives the spinothalamic and the dorsal column medial lemniscus pathway. The spinothalamic pathway is responsible for the pain and temperature, and the DCML pathway is responsible for the proprioception and the pressure. Okay, and light touch also, and the two finger discrimination, right? So all these senses, whenever they're received by the peripheral nerves, they will travel all the way to the spine. Okay, and then from the spine they will reach to that area, the ventral posterolateral, the VPL. Okay, and from the VPL it go to the respective areas which are the primary somatosensory cortex. Okay, which is present just after the this posterior to the premotor cortex, right? The primary motor cortex, sorry. Okay, just behind the central sulcus. Okay. Second, you have the ventral posterior medial, the VPM. Okay, and all these inputs from the face, they will reach first to that area. That means the trigeminal and the gustatory pathways. Okay, the inputs are senses from the face, from the taste. Okay, and what nerve takes the taste?
anterior two-third by quadrant tympani and the posterior one-third by uh, the ninth nerve.
Okay, and
glossopharyngeal.
10th also. Okay, 7,
Yeah,
9, 10, 12th, right? Okay, so they again, because they are sensory inputs, they will reach to the primary somatosensory cortex. Then you have the geniculate nucleuses, the medial and the lateral. You can remember lateral for light and medial for music. Okay, so lateral for light, it will be taken by the second cranial nerve. Okay, all this optic chiasm, optic tract, and ultimately they will reach to the lateral geniculate nucleus. Okay, and they're responsible for the vision, right? From the lateral geniculate nucleus. Okay, all these radiations will be there, and they will project to the primary visual cortex, which is in the where
occipital lobe.
in the
Occipital.
occipital lobe. Okay, then you have the middle geniculate nucleus, and they're responsible for the hearing or the music, right? You have the ventral lateral nucleus, okay, and it is responsible for the motor inputs. Now, as you can see, you're receiving all these vibrations, pressures, taste, face sensations, vision, hearing, motor, but you're not receiving any olfactory senses from the to this hypothalamus. Oh, sorry, this thalamus, right? So olfactory impulses, they do not travel to the thalamus. Okay, they will reach directly to the this temporal lobe, right? Bypassing the thalamus. So all the senses except the olfactory senses, they will reach directly to the temporal lobe, not to the thalamus. Is that okay?
Yeah.
Yes.
So remember medial for the face, VPL for all these senses, little geniculate, middle geniculate for light and music, and ventrolateral for the motor. Now you have the limbic system for the memory, you can say. Okay, it is for the memory, it is for the feeding whenever you are hunger, whenever you are feeling something, whenever you want to fight with someone, whenever you want to express your feelings. Okay, whenever you want to run from a situation. Okay, all these functions are performed by the limbic system. Okay, so basically our higher functions, okay, they will be performed by the limbic system. It is responsible for the memory, for the emotion, for the olfaction, okay, your behavior, your ANS function, right? You don't need to remember every function, just measure 2 3 functions, which are the memory first, the long-term memory especially, okay, as well as all these the feelings, okay, the emotions and your behavior. These 3 functions you must remember. These are performed by the limbic system. Okay, certain structures are there which contribute to the limbic system. These are the amygdalas, hippocampus mainly, mammillary bodies you have, okay, antithalamic nuclei, and a cingulate gyrus. We will discuss all of these nucleuses later. Okay, just know the name for now: the amygdala, hippocampus, mammillary body, antithalamic nucleus, and the cingulate gyrus. These are all contribute to the limbic system. Okay, you have one disorder which is associated with the damage to this limbic system, and this is a transient global amnesia. Okay, it happens whenever you got damage in the this hippocampus. Okay, very important, and because of that, the patient will have an anterograde amnesia, which means he will forget everything just after the episode. Whenever that particular damage occurs, okay, the patient will forget everything after that damage. Okay, so the patient will have a self-limiting anterograde amnesia. Okay, if you tell them your name, they will forget it after 5 minutes. If you tell them anything to remember, they will forget it after 5 minutes, and they will ask you what happens, because they have no memory of that event, right? What happens with them in during these 5 or 7 minutes, they have no memory of them. So they will repeatedly ask you questions like what happens, where am I, what happens, right? So they will have the repetitive questioning. They will have a self-limiting anterograde amnesia. Okay, it is because of a dysfunction in the hippocampus. Okay, they are unable to form new memories. They cannot recall the physician's name. Okay, but their past or their distant memory is totally intact. Okay, they remember their name, they remember their family, they remember where they live, but they don't remember new persons. Okay, they don't remember what's happening to them now. Okay, so they will repeatedly ask you questions like what happens. Okay, so whenever you encounter this kind of a patient, please note this is a transient global amnesia, and it is because of a dysfunction in the hippocampus. Okay, any doubt?
Do we have to remember like that image which is shown in the limbic system?
You will eventually remember it, don't worry. Okay, you can just forget it for now. Later we will discuss all these nuclei where they exist in the brain. Okay,
Okay. Okay. Thank you.
so just wait for that. And please note, whenever you have a deep emotion with some memory, with some incident, okay, with some event, if you have a deep emotion, okay, the memory will be a long-term memory. If you have a very little emotion with that particular incident, with that particular event, you will have a very a very superficial memory will be there. Okay, not a long term, but a short memory of that event will be there. You will eventually forget it. Okay, so deeper the emotion, okay, longer is the memory of of this incident. Okay, then the dopaminergic pathway is very important. Okay, all that psychosis you will hear, the Parkinson's disease you will study, all these are associated with these dopaminergic pathways. Okay, so note that you have four major pathways: the mesocortical, mesolimbic, nigrostriatal, and the tuboinfundibular. Okay, the mesocortical, it will transmit the impulses to the cortex. Okay, and they're responsible for the negative symptoms of the psychosis. In psychosis, you will study, you have two symptoms: the positive symptoms, which are for the overactivity, and the negative symptoms. Okay, for a decreased activity, and like apathy. Okay, and decreased interest in everything. Okay, social isolation. All these are because of these negative symptoms, and that's because of activation of the mesocortical pathway. Okay, second, you have the mesolimbic pathway. Okay, it transmits all the impulses to the limbic system, and these are responsible for the positive symptoms. Okay, so whenever the activity of this system increases, you will have the positive symptoms, and that includes the delusions, hallucinations, right? The disorganized speech you will get, all that because of activation in the mesolimbic system. Okay, and whenever you got an inhibition of the mesocortical system, you will get the negative symptoms. So when you give the patient the antipsychotic drugs, tell me what these drugs do.
Reduces the activity of these amines.
So basically they inhibit the dopamine receptors, right?
Yeah.
And you guys know that the negative symptoms are because of inhibition of this pathway. That means inhibition of the dopaminergic neurons there. Okay, and the positive symptoms are because of activation of the dopaminergic neurons in the mesolimbic system. So if you give the patient the antipsychotics, the typical ones I'm talking about, so they will inhibit this activity, this mesolimbic system activity. So you will get the rid of the positive symptoms. Okay, but they're also inhibiting the mesocortical system, so they can worsen the negative symptoms also. Is that okay?
Yeah.
Good. And when you give the patient the atypical antipsychotics, now they are very important ones. Okay, because they by would they inhibit both the dopamine as well as the serotonins, right?
Yeah.
Getting my point? So the atypical antipsychotics, because they inhibit both the dopamine as well as the serotonin. Okay, and the serotonin is responsible, okay, for the inhibition of the dopaminergic neurons in the mesocortical pathway. Okay, serotonin is responsible for the inhibition of the mesocortical pathway, the dopaminergic neurons there. So when you inhibit the serotonin, okay, so ultimately you're activating this pathway, right?
Right.
And that's why in case of atypical antipsychotics, okay, you're getting rid of both the negative symptoms as well as the positive symptoms. Is that okay?
Yeah.
Okay. Now you have the nigrostriatal pathway, which is responsible for the movements. Okay, and whenever the activity of this pathway decreases, you will get the extrapyramidal symptoms like the Parkinsonism, like the tardive dyskinesia. Dystonia will be the acute symptom. Okay, then you will get the akathisia, in which you have the restlessness of the leg or any part of your body. Okay, you will have the urges to move your body parts, right? Parkinsonism will be there, the tardive dyskinesia will be there, in which you have the chorea-like symptoms. Okay, so all these are because of inhibition of the nigrostriatal pathway, and all these are the side effects of the antipsychotic therapy, right? And finally, you have the tuboinfundibular pathway. Okay, and this pathway is responsible for the inhibition of the prolactin. Okay, and you guys studied that already in the endocrine section. Okay, so when you inhibit this pathway, will be inhibiting the dopamine so that you're activating the prolactin. You will have a decreased libido, sexual dysfunction will be there, galacturia will be there, gynecomastia will be there. Right? Any doubt?
Could you please tell what happens to the serotonin activity because of atypical antipsychotics?
See, in case of psychosis, you're having a high activity of both the dopamine as well as the serotonin. Okay. Because of high activity of dopamine in the mesolimbic system, you're getting a positive symptoms. Because of high activity of serotonin in the mesocortical system, you're having inhibition of the dopaminergic neurons. And as a result, you're having a negative symptoms, right?
Okay, yeah.
So if you inhibit that pathway, okay, if you inhibit the serotonin, you're actually activating the mesocortical pathway. Okay.
Right. Yeah.
And by activating this pathway, you're getting the rid of these negative symptoms from the negative symptoms, right?
Okay, yeah. But thank you.
Then you have the cerebellum. Okay. And for the cerebellum, you first need to identify its part. In the center, you have the vermis. And does anyone remember in what disorder you're having a herniation of this vermis?
CRE malformation 2.
Yeah, in the Chiari malformation too. Okay. So you have in the central the vermis. Okay. And you have two cerebellar hemispheres. You can divide these hemispheres into the two parts. One is the intermediate and second is the lateral. So you're having the vermis in the center. You're having the intermediate lobe just lateral to the vermis. And then you're having a lateral lobe. Okay. And then you can draw this kind of a human. Okay. And from that picture, you can know that the central part of the body is controlled by the vermis. Okay. All this motor execution of the central part, the gait management, it is done by the vermis. Then you have the intermediate lobe, which basically does the motor execution of the peripheral part of your, like your limbs. Okay, the motor activity of these limbs will be by the intermediate lobe. That means by holding a pen, and and this writing something. Okay, it is all done by the intermediate lobe. Okay, the lateral lobe is for the planning and coordination. Okay, like whenever you walk, you want to move your legs and your hands in the opposite direction. So it is all done by the lateral lobe. How you want to hold the pen, it is all determined by the lateral lobe. So this lateral lobe is for the planning and for the coordination. Intermediate lobe for the motor execution of the peripheral parts of your body, like your limbs. And the vermis is for the central part of the body, right? Like the gait management. Okay. Then you also have the nodular lobe, which is responsible for the eye movement. Okay, and the balancing also. Now, whenever you get a damage of the vermis, because it controls the central part of your body, what you will get is the truncal ataxia, and it will present as the wide base gait. The patient will move with their legs spread, okay, so that they won't fall. Okay, so this is the broad base gait you will get whenever you get a damage of vermis, and you can see that this foculonodular lobe is also lie very close to the vermis. So whenever you have a damage to the vermis, you will also get a damage to the foculonodular lobe. And by that damage, you will get the nystagmus and you will get the vertigo because it is responsible for the balancing and for your eye movements also, right? So we'll get the inhibition of the balancing as well as disorganized eye movements. So we'll get the nystagmus as well as the vertigo. Now, with the intermediate lobe damage, okay, or you can say a complete lateral hemispheres, whenever they get damaged, what you will get is the limb dysmetria. Okay, you will get the intentional tremors, like whenever you want to move your hand, okay, for a targetoid movement, okay, you will get the tremors, like by holding, whenever you progress by for holding any pen or any vase or any glass, right, you will have the tremors while doing that. You will have a dysdiakinesia. Okay, that means impaired rapid altering movements. Okay, so they will get damage. Okay, and yeah, so that would be the symptoms of any intermediate hemisphere, or you can say any of this cerebral hemisphere damage, right? So that's what everything, uh, that's a summary of all these things written in that paragraphs. Okay, you have the code, the so the inputs of the cerebellum will be received from the contralateral cortex. Okay, like if I want to draw, You have two cerebral hemispheres, the cerebral hemispheres, and you have two cerebral hemispheres. Okay, and the inputs are received by the contralateral cortex. Okay, the contralateral cortex will send the inputs. Okay, you will have the proprioceptive, all these fibers for the proprioception. Okay, they will reach ipsilaterally. That means for the right limb, if this is my right limb, okay, any proprioception sensing, that means a pressure or any light touch, okay, or any positional sensing, okay, it will transfer to the ipsilateral cerebellum. Okay, very important, and that could be done by the inferior peduncle. Okay, and the inputs from the cortex are received by the superior peduncle. Oh, sorry, the middle and as well as superior also, right? So inferior, okay, for the spinal cord, and that's from the limbs. Superior middle for the cortex. Okay, these are the inputs from the cerebellum, right? Any doubt in that part?
No, thank you.
Now, outputs are mainly by the Purkinje cells. Okay, very important to note. Outputs are mainly by the Purkinje cells, and the outputs are always inhibitory in nature. Okay, this is an important point. The outputs are always inhibitory in the nature. Okay. Now, if you got a lateral lesion, we have discussed, you will get the very affected. You will affect the voluntary movements of the extremities. Okay, and the patient will fall towards the injured side. That means on the ipsilateral sides, because you know that all the fibers that are running from the that are running for the cerebellum, they will be running from the ipsilateral side of the body, right? The same side of the limb. So patient will fall on the same side. If you have a if you have any of the medial lesion, you will like for the vermis and the focinodal lobe, you will get a truncal ataxia, right? You will get a nystagmus, you will get the head tilting towards the lesion. Okay, very important. So yeah, that would be all about the cerebellum. Any doubt? Any doubt?
No, thank you.
Now, if you guys go back to general pathology, we have discussed, one paraneoplastic syndrome, okay, which is associated with the small cell lung cancer that can damage all the Purkinje cells of the cerebellum. Remember?
Subacute cerebellar degeneration.
Yeah, exactly. So just give me a second. Yeah. The subacute cerebral degeneration, which is a paraneoplastic syndrome, in which you have this anti-Ju, anti-PQ antibodies. Okay, and these antibodies are actually formed for the small cell lung cancer, but they cross-react with some antigens present on the Purkinje cells, and as a result, what you will get is the the degeneration of the Purkinje cells. On the biopsy of the patient, you will see the degeneration of the Purkinje cells. You will immediately know that it is a paraneoplastic syndrome for the small cell lung cancer. Okay, so it is because of the cross reaction of the antibodies that were formed initially against that tumor. Okay, but they cross react with my Purkinje cells, and as a result, now my Purkinje cells are being damaged. So you will see the the degeneration of all these Purkinje cells, right? And you call it a paraneoplastic cerebellar degeneration. It is seen in the small cell lung cancer. Okay, you can also get in the breast cancer, right? As well as the some Hodgkin's lymphoma also. Okay, so what symptoms you will get? You will get the ataxia, right? You will get a dysgenesis, you will get a dysarthria, you will get a diadokinesia, right? You will get a dysmetria. All the symptoms of the cerebellum would be present. Any doubt on this page so far?
No, thank you.
No.
Excuse me.
So what is dysmetria? Anyone? What is dysmetria?
Unable to count the fingers.
Oh, now you can. That's a different thing.
It's like
I mean,
pass
that
point.
could be, yeah,
Unable to touch the nose, pass pointing, and then the
exactly.
thumb.
Whenever you ask a patient to touch something, to hold something, they cannot hold it. Okay. So that is the dysmetria. Okay. They will overpass that object or they will underpass that object. Okay. Whenever you ask them to hold something like touching the nose, they will have the overshooting, right? They are unable to touch their nose. So this is how you perform the dysmetria. Okay.
Okay.
For diadochokinesia, you will be having a impairment in the rapid altering movements. Okay. So please remember the dysmetria and the diadochokinesia, and you can also have the intentional tremors. Okay. So that happens whenever you want to perform an interarticular movement, right? Now you have the basal ganglia. Okay. And let's discuss the cross section of your brain. Okay. Step one will give you this kind of a cross section on the CT or MRI of the patient. They will point at any area of the brain and they will ask you that the damage, if that area happened, okay, what symptoms the patient will get, what disease patient can get, right? So in the center, you can start it by like that. Okay, so first of all, look for the ventricles, these spaces in the brain. Okay, in the very center, you're having this third ventricle. Okay, and the laterally you have these lateral ventricles. Around the third ventricle, laterally, okay, you're having the hypothalamus. Sorry, you're having the thalamus, right? Just below the thalamus, you're having the subthalamus. Okay, in the center, in the very center, because you know that the hypothalamus is a very central structure. In the very center, just below the third ventricle, you're having the hypothalamus. So, you know, this subthalamus has this name because it is present just below the thalamus. That's why the name subthalamus. In the very middle, you're having this thalamus. Okay, just below the subthalamus, you're having the substantia nigra pars compacta. Okay, the SNC. Okay, and this is a midbrain structure. You must remember, substantia nigra pars compacta is a midbrain structure. Okay, located just below the subthalamus. Just below your hypothalamus, you're having the mammillary bodies. Okay, as you can see here. Okay, now comes the above part. You have the lateral ventricles, and just lateral to the lateral ventricles, you're having the caudate nucleus around them. Okay, lateral to the thalamus, okay, you're having the lentiform nucleus that contains two parts. One, and the outer one is the putamen, and the inner one is the globus pallidus. The outer one known as the globus pallidus externus, and the inner one known as the globus pallidus internus. Okay. Now, lateral to your mammillary bodies, okay, that means this part of the brain, okay. In the very middle, you're having this amygdala, and lateral to it, you're having the hippocampus. Okay. On this part, as you can see on this part, you're having the insula. Okay. So start with the central openings. Okay, the third ventricle and the lateral ventricles. Lateral to them, thalamus, just below thalamus, subthalamus, middle to it, hypothalamus, below it, substantia nigra pars compacta, below it medially, mammillary bodies, lateral to them, amygdala, lateral to them, hippocampus. Lateral to thalamus, you're having the lentiform nucleus. Above the thalamus, lateral to your lateral ventricles, you're having the caudate nucleus. Any doubts so far on that parts?
No, thank you.
Okay. Now you need to know about these two structures, which are the striatum and the lentiform. Striatum is basically the putamen. You collectively, you know, this caudate nucleus and the putamen. Okay, these are called as the striatum. Okay, and lentiform, the this putamen and the globus pallidus together, they call it the lentiform nucleus. Okay. Now, this basal ganglia is actually responsible for the movements, for the voluntary movements in your body. Okay, like whenever you want to move one limb, you want the inhibition of other. Whenever you want to flex your limb, you want the inhibition of the extensor parts, right? So all these coordinated movements are performed by the basal ganglia. Both the direct pathway, which is the excitatory pathway, and the indirect pathway, which is the inhibitory pathway, okay, they occur simultaneously. The inhibitory pathway will be inhibiting all these muscle groups which are not required for the movement, and the activatory pathway or the excitatory, the direct pathway will be activating all these muscle groups which are responsible for that movement, which are needed for that movement. Is that okay?
Yeah.
And you don't need to go in a very further deep to these pathways. You just need to remember that this globus pallidus internus, and it has I. That means it is responsible for the inhibition, and the GPE, which is globus pallidus externus, it has E, and it is responsible for the excitation. Okay, whenever the GPI get activated, it will inhibit the thalamus, and you guys know that the thalamus, all these motor impulses will travel through the thalamus, right? So it will inhibit the thalamus, and you will get the inhibition of the motor activity. Whenever the GPE sends signal, okay, it will inhibit my substantia, by this, sorry, the subthalamic nucleus, which is present just below my thalamus. Okay, and as a result, I'm inhibiting my GPI, so that this GPI cannot inhibit the thalamus. So ultimately, you can see that whenever the GPE got activated, you're having activation of the thalamus. Whenever the GPI got activated, you're having an inhibition of the thalamus. And the GPI will get activated whenever my subthalamic nucleus sends signal to it. Okay. So whenever my subthalamic nucleus get activated, it will activate the GPI, which ultimately inhibit my thalamus. Okay, so I will be having the inhibition of all these muscle groups, which are not responsible for the desired movement. Okay, so now you have two type of dopamine receptors. Okay, the D1 responsible for the direct pathway, and the D2 responsible for the inhibition of indirect pathway. Okay, because you're you're always having the activation of this direct pathway. Okay, whenever you want to perform some movement, okay, you need to inhibit your indirect pathway for the desired muscle group, and you want to activate the direct pathway for the desired muscle group. For example, if I want to flex my hand, okay, now for the flexion, my indirect pathway initially was activated, and the direct pathway was inhibited, you can say. Okay, whenever I want to flex my arm, I want the flexor muscles group to be active. In that case, I will inhibit the indirect pathway controlling my flexor groups, and I will activate a direct pathway controlling my flexor groups. And because by default you're having the activation of this indirect pathway in the extensor group, so my extensor group will be inhibited and my flexor group will be activated. Are you getting my point?
Could you please repeat this last sentence?
See, this is my limb. Let's say this is my arm. Okay, and this is my forearm. Okay, now I have both the GPE as well as a GPI. Okay, controlling my flexor group. This is my flexor group. Okay, and I have again the GPE and the GPI controlling my extensor groups, right? Whenever
Yeah.
I want to flex my hand, okay, because the inhibition will be always there. Okay, inhibition will always be there. You need to excitate your arms, right? Now, whenever I want to flex my hand, I need to inhibit this inhibition, and I want to activate the excitatory pathway so that the contraction can happen, right?
Yeah.
Yes.
And by default, I always have the inhibition pathway activated. So if I do not inhibit this pathway, I will have the inhibition of the extensor group, but I have this activation of the flexor group. Is that okay? And that's how I get a limb flexion.
Okay. Okay. Yeah.
You still not get my point?
It's a little confusing. I studied it long back.
Yeah.
That's why.
See, you have both the inhibition as well as the excitation. Okay. To move any muscle group, you need to inhibit the inhibitory pathway and you need to excitate the excitatory pathway. You need both the things, right?
Yeah.
By default, my limb is in relaxed position. Okay. Now I want to flex my limb. In order to flex my limb, I need to inhibit the inhibitory pathway and I need to activate the excitatory pathway, right?
Yeah.
If that happens, if I inhibited this pathway and I activated this pathway, I can get the flexion of the limb. Okay.
Right.
But you know that the extensor groups are also there and they need to be inhibited first in order to get a flexion, right?
Yeah.
Yeah.
And by default, because you guys know that the inhibitory pathway is always there, my extensor groups are inhibited already.
Yeah. Yeah.
Mhm.
So
Oh.
as you can see, at some places I'm inhibiting my movement and at some places I'm getting some movements, right?
Right, right.
That's why all this inhibitory pathway and the excitatory pathway are needed to inhibit all these muscle groups which are not desired for the movement and to activate all these muscle groups which are responsible for that movement, right?
Yeah,
Yeah.
And just
yeah.
know,
Cool.
and importantly note that the GPI sends the inhibitory signals, okay, and that happens whenever the subthalamic nucleus activates it. So the subthalamic nucleus and the GPI inhibit the thalamus, and the GPE will activate the thalamus. I will get the signals from the D1 neurons. They will stimulate the D1. They will send signals from the cortex to the my putamen. The putamen sends signals to my GPE. The GPE will get activated. Whenever my GPE gets activated, it will inhibit the subthalamic nucleus so that my GPI will be inhibited. You don't need to go for all these pathways. No one will ask you. Okay, but just know this summary because it gets so much confusing. You know who is inhibiting whom, and by inhibition and inhibition you're ultimately getting the activation, so it is kind of so much confusion to learn. Okay, just learn the superficially things, the summary, that the GPI and the subthalamic nucleus is responsible for the inhibition of the thalamus, and the GPE will be responsible for the excitation. The GPE will be under a direct control of the D1 neurons, and the GPI and the subthalamic nucleus are under the control of D2 neurons. The D2 will be inhibition and the D1 will be excitation. Is that okay?
Yeah.
Yes.
So whenever I get the activation of D2, I will be inhibiting these structures. Whenever I get the activation of D1, I will be activating these structures, right?
Yes.
Yes.
Okay, good. Now just give me a second so that I can correlate it with the pathology you're going to study. Okay, see. You have two conditions. One is the Parkinson's disease, okay, and second is the hemibilismus, okay. One is the Parkinson's disease and second is the hemibilismus. In the hemibilismus, you're having too much of the movements, okay, and that because of a damage in the subthalamic nucleus. See, whenever you got a damage in the subthalamic nucleus, there is no one to inhibit your movements, right?
Yeah.
So what you will get is the sudden wild failing movement of one side of the body to the side where the subthalamic nucleus got damaged, right? And this is known as the hemibilismus. Okay.
Yes.
Yeah.
Second, you have the Parkinson's disease. Okay. And in the Parkinson's disease, you're actually having, just give me a second. Yeah. You're actually having a very too much activation of the GPI and the subthalamic nucleus. And because of that, you will have the rigidity in the movement. Okay, you will have that all this pin rolling tremors at the rest. Okay, that because of the that's because of activation, super activation of this GPI and the subthalamic nucleus. So in order to treat the Parkinson's, okay, one of a desired treatment, a surgery you can say, is to inhibit of these neurons, these nuclei, right? If you inhibit these nuclei somehow by surgery or by any laser treatment, okay, you can get the relief of symptoms of the Parkinson's, right? And if you damage these neurons in a normal individual, what will happen? You will have a hyperactivation of the muscle group. So you will get the hemibilismus. Is that okay?
Yeah, yeah.
Yes.
So hemibilismus is because of damage to the subthalamic nucleus so that you can get a hyperactivation of the muscle groups. And the Parkinson's is because of hyperactivation of these of these nuclei so that you will get a rigidity in movement of any muscle group. Any doubt so far on this basal ganglia?
No, thank you.
Okay, now I hope you will be able to memorize and remember and understand all this basal ganglia pathway and all these things, right?
Yes.
Yes.
Okay. Now you have the cerebral cortex regions. Okay. First, you need to identify the central sulcus. Okay, Stephen will give you all this image. Okay, and they will ask you about a certain. So they will give you sometimes a history of any seizure. Okay, sometimes they will give you any history of a stroke. Okay, and they will ask you any history of aphasia, and they will ask you what part of the brain got damaged. They will give you this kind of a figure, and then you need to identify all these centers, right? So first look for the central sulcus. Okay, this one. Anterior to it, you are having the primary motor cortex. Posterior to it, you are having a primary somatosensory cortex. The somatosensory cortex responsible for any senses in your body, the proprioception, pain, temperature, pressure, touch, light touch, fine touch, hard touch, everything, right? Motor cortex is responsible for the voluntary movements in your brain, in your body, right? And does anyone remember if you have a damage to the this cortex, in what disease you can get the atrophy of this primary motor cortex? Anyone? No? Amyotrophic lateral sclerosis. Okay, ALS. Are we good?
Yeah. But in ALS, isn't the neurons of the spinal cord damaged?
See, it has both the upper motor neuron as well as the lower motor neuron. Nowhere mentioned that it only includes the spinal cord. In the FA also, it has mentioned both the upper motor neuron and the lower motor neuron. So in any pathway of your motor activity where the upper motor neurons are present, they will get damaged. And whenever the upper motor neuron can get damaged, so this primary motor cortex is nothing but a collection of all these upper motor neurons, right?
Yeah, yeah.
If they get damaged, you will get the atrophy of this motor nucleus, right?
Right.
Yeah.
Okay, good. Now, anterior to my primary motor cortex, you're having the premotor cortex, okay? And it is responsible for the coordination of the movement for the planning functions, right? Then you have the frontal eye field, which is responsible for the eye movement, the gaze movements specifically, if I want to say, okay? Then you have the prefrontal cortex, and that area of your brain, it coordinates with the limbic system of your brain, right? So this area is also responsible for the behavior, for the emotions, for the feelings, okay? And whenever you got any damage in the prefrontal cortex, okay, what you will get is a change in the behavior, aggression, okay, hyperphagia, hyperorality, hypersexuality, and that is known as, this classical trait will be seen in what disorder? The Clever-Bussy syndrome, remember?
Yeah, yeah, yeah.
Okay, so do note that you can get that syndrome, okay, with the damage of this prefrontal cortex also, okay, because this area of your brain, it coordinates with the limbic system, okay, it will send all this information to the limbic system, right? So if damage to that area happen, you can get the Clever-Bussy syndrome also, okay. And also, if you get a damage of the amygdala, that happens normally, okay, if you get a damage of the amygdala, you can also get the Clever-Bussy syndrome like features. I mean, the true Clever-Bussy syndrome is because of this amygdala damage, but the symptoms like this syndrome is also present if you get a damage in the prefrontal cortex. Remember the frontotemporal dementia?
Yeah.
Yeah.
We studied that later, the frontotemporal dementia, and that all happened because of a damage to your prefrontal cortex. So you will get a very change in the behavior, hypersexuality will be there, hyperorality. So all these features will be resemble the Clever-Bussy syndrome, right? We will hear that again, don't worry, in this class, I hope. Okay. So do remember the prefrontal cortex, it coordinates with the limbic system. Okay. So it is also responsible for all these emotions, behavior regulation. Then you have the Broca's area, okay, which present just above your the Sylvian fissure, which you can see, which basically separates the frontal lobe with the temporal lobe. Okay, so just above that you have the Broca's area, okay, and near the primary motor cortex. So whenever you get a damage of the primary motor cortex, you always get the aphasia. Okay, because these two areas are in very close association. So any blood vessel with supplying this primary motor cortex area is also supplying the Broca's area. And whenever you get any embolus, whenever you get any stroke or any ischemic stroke, okay, what you will get is the damage to both the primary motor cortex as well as the Broca's area. So they two, generally happen together. You will get the paralysis as well as, the aphasia. Is that okay?
Yes.
Yeah.
Then posterior to my primary somatosensory, you have the somatosensory association cortex. Okay. Then you have the primary auditory area also, which is just below your primary somatosensory cortex. Okay. In the very anterior part of your temporal lobe, you're having the limbic system. Okay. Because, if I go back, this part, this area is nothing but your temporal lobe, right? This is your the frontal lobe. This is a temporal lobe. In between, you're having this midbrain. If you guys look, right, as you can see on this part also, in this part you're having all these this amygdala and the hippocampus, right? So these are basically the nuclei which are present in the temporal lobe. Is that okay?
Yes.
So in the very interior, I'm having a limbic association area, right? In the very posterior, I'm having the Wernicke's area, which coordinates with the Broca's area for the speech, right? It basically does the comprehension of everything you say. If someone want to give me a command, if someone gives me any command, like to lift a table lamp, okay, all these command will be comprehended in the Wernicke's area. In order to understand any command for speaking, for performing any function, I need this area to be intact. Okay, very important. And then you have the arcuate fasciculus, which basically help coordination in between the Wernicke's area and the Broca's area. If a damage to a Broca's area or the Wernicke's area or this arcuate fasciculus happen, what we will get is the aphasia. And we will discuss all the features of different type of aphasia later in the chapters. Okay, but just for here now, remember, in the arcuate fasciculus, in the Broca's area and the Wernicke's area, you will get the aphasia. Then in the occipital lobe, you're having the primary visual cortex. Remember the lateral geniculate body, it sends all the signals to this primary this visual cortex, right? So yeah, that would be all about these areas. Any doubt?
No, thank you.
No, thank you.
Now, you need to also remember a difference between the aphasia and the slurring of the speech. Okay, if the patient is having any slurring of the speech, okay, and it dysarthria, which means they want to say something, they actually can say something, but it just their muscles got paralyzed. Okay, so this is known as a slurring of the speech, and that happens because of a damage in the primary motor cortex, because ultimately Broca's area coordinating with this primary motor cortex to cause the movement of my jaw, of my tongue, so that I can speak something. If that area can get damaged, what I will get is a dysarthria and the slurring of the speech. If I get a damage of the Broca's area, what I will get is the expressive speech, in which I cannot express what I want to say, right? And this is known as agrammatic speech also, right? So know the difference between the slurring of the speech and the agrammatic. Yeah. Any doubt? Okay. And you guys heard about the all these seizures, right? The focal neurologic these seizures, the focal seizures, right?
Yeah.
So whenever a seizure happened, it's just because of a overactivity of any of these areas. For example, if I get an overactivity in the primary motor cortex, what I will get is the seizures in my hand or in my leg, depending upon the part of the motor cortex involved. If I get any seizure from the primary somatosensory cortex, I begin feeling, any sensory inputs, like, okay, like, any kind of insect on my body, let's say. Okay, so these kind of senses I get, and I will say that the patient is having a seizures. When I get any seizure originally from the primary visual cortex, what I will see some flares, some flashes, okay, some auras I will see. If I get a seizure from the primary auditory cortex, I begin to hear something unusual voices. Okay. If I get a seizure originating from my occipital, from my olfactory lobe, okay, what I will see in the seizures, I will smell something unusual like a burnt of a tire, right? Whenever I got any seizure from the Broca's area, I begin to say something, without any meaning. If I got a seizure from my frontal eye field, I will be having an nystagmus in my eyes. Okay, so looking for the features, whenever a patient got any seizure, it is all because of a hyperactivity of any of these areas. These areas will get any hyperactivity, and so that I will get the respective symptoms associated with all these areas. Is that okay?
Yes.
We will revise these concepts again in this in the seizure section. Okay, and the seizures happen whenever I got any trauma, whenever I got any stroke, whenever I have any tumor, or sometimes they're idiopathic also, right? So that's why whenever you got any seizure, you always have to perform the MRI to make sure that there is no structural lesion present, like any tumor or like any stroke. Okay. So, that's how you can correlate these areas with the seizures also. Now you need to study about the cerebral perfusion, although we got a basic idea in the previous section already, right? So now just study again. So we have discussed that whenever, all these vessels in the brain, they respond to the CO2. Whenever you have a high CO2, these vessels will get dilate so that more blood could enter my brain. Whenever I got a low CO2, these vessels will get a vasoconstriction happen. Okay. And as a result, less blood will go to my brain. Now, these vessels will respond to my CO2 up to a certain level only. When the CO2 levels become too high or become too low, okay, the vessels will stop responding to the CO2. Similarly, these vessels they do not respond to my oxygen, but whenever a very low oxygen present, whenever the hypoxia happens, okay, then instead of the CO2, the vessel will start responding to my oxygen. So whenever I have a low oxygen, which is less than 50 mm of Hg, okay, my these vessels, the brain vessels will start responding to the CO2. And whenever my CO2 whenever my O2 decreases, I will get the vasodilation, because ultimately the brain need oxygen, right? Whenever a high CO2 present, the blood vessel, this blood flow must be increased to get the required oxygen demand fulfilled, right? Similarly, whenever I have a low oxygen, I need to increase the blood flow to meet my metabolic demands, right? And that's why whenever I have a low O2, I will get the vasodilation. So as you can see in this graph, this is my the mean arterial pressure, right? As you can see, whenever I have a low oxygen, as you can see, the blood vessels are not responding to my O2. But whenever I get a O2 less than 50, the cerebral blood vessels will start responding to my O2. Vasodilation will happen, and as a result, the cerebral blood flow will be increased. These vessels will be responding to my CO2. Whenever I have a high CO2, as you can see, the CO2 is rising, rising, rising. Similarly, the mean arterial pressure will be rising, as you can see, right? And this is my constant area. Sorry, I got confused. Oh, so this is the partial pressure of my CO2. Okay, as you can see, as the CO2 is rising, right? This is the cerebral blood flow will be very much okay, increased, right? As you can see, but after a certain time, as you can see here, okay, after the 100 pp, it is mentioned 90, but you can see the 100 also, right? After the 100, the cerebral blood flow will stop responding to my CO2, and it will become constant. And when the CO2 levels are dropping, okay, the cerebral blood flow will also dropping, but up to a certain level only. Like you can say after 20 or 30, okay, they will stop responding to my CO2, and it will become constant. So this is about the CO2 and the oxygen. Whenever I have this high oxygen, it won't respond to the oxygen, but whenever I have a low oxygen, less than 50, my brain will respond to the oxygen only then. For the CO2, it will respond between 30 to 90, you can say. After 90, it will stop responding. For the CO2, it will become very constant. Okay, so this is a one thing. Second is the mean arterial pressure. You need to remember this equation, okay, that the cerebral perfusion pressure is directly equals to the mean arterial pressure minus the intracranial pressure. which makes sense because, you know, you're having this brain, okay, and you have this central organs, the central body. In the central body, you're having this mean arterial pressure, okay, and on the brain, you're having the intracranial pressure, right? In order to move the blood from my heart to my brain, I need a pressure gradient, right? And that means the pressure on this side must be higher on this side, right?
Yeah.
Yes.
And that's why I will get this equation. Okay, how much perfusion pressure I get in my brain, it depends upon how much map was there and how much intracranial pressure was there. Okay, in a scenarios where I'm having a very high intracranial pressure that happens because of any stroke, okay, I will be having a decreased cerebral perfusion. As you can see, whenever I having any edema, okay, the perfusion in my cerebellum will be decreased. I will get the ischemia there. Similarly, in case of map, whenever I have any shock, whenever my map fails, like in case of anaphylaxis or any case of, and you know, any case of shock, I'm getting a low map, and as a result, the perfusion to my brain got decreased, and what I will get is a syncope, right?
Yeah.
Yes.
So remember that function also. Now, because you guys know that my brain is responding to the CO2, okay, in a scenarios where I'm having a high intracranial pressure, okay, if I give the patient low CO2, okay, in that case, I will decrease the cerebral blood flow, right?
Yes.
Yes.
And this is a mechanism to prevent the edema secondary to the stroke or any trauma. Whenever I encounter a patient having a hemorrhage or having any stroke, okay, and he's having a very high intracranial pressure, in order to decrease my intracranial pressure, I need to decrease the CO2. And as a result, the vasoconstriction will happen. The blood flow to the cerebellum will be decreased, and I will get a decrease in the intracranial pressure also. Is that okay?
Yeah. Yeah.
Yes.
And this is known as the therapeutic hyperventilation. Okay.
Yes.
Okay. Any doubt?
No, thank you.
No, thank you.
This is the point about the seizures we have made. Okay. The symptoms of the seizures is totally depends upon which part of the brain the seizures has been originated, right? If it's from the sensory cortex, then sensory symptoms will occur first. Now, sometimes what happens whenever, let's say, a seizure originates from my somatosensory cortex, so the first symptom I will get in my seizure are the senses, abnormal senses, like someone crawling on my chest. Okay. Now, whenever the hyperactivity of this area happen, okay, symptoms will get unilateral first. Now, the primary somatosensory part of other cortex also, it will also be, you know, involved, right? And what I will get is the bilateral symptoms. So first I will get the unilateral symptoms, then I will get the bilateral symptoms, then soon this somatosensory part will also involve the motor cortex. Now the hyperactivity will start happening in the motor cortex, and what I will get are the motor symptoms in the seizures. Okay. Or this tonic contractions and relaxations I will get. Okay. So first, so in order to identify where the seizure have been originated, you need to look for the first symptom the patient had, whether it is a sensory symptom, whether it is any flash of light or any aura or any, any kind of abnormal smell, abnormal hearing. Okay. Because soon, all these seizure areas, they will eventually involve all of these areas surrounding, right? And you will get a very diffuse kind of symptoms. Okay. That's what I mentioned here. Okay, so whenever any seizure originates in the premise on this somatosensory cortex, what you will get is the numbness and the paresthesias. Okay, soon on the contralateral body. Okay, then on the, and you will get the involvement of the lateral brain, this motor cortex. So what you will get is the convulsions. So the first symptom would be the paresthesias or any kind of sensory symptom. Okay, and then soon you will get the motor symptoms again, right? That's how all these waves will travel in case of seizures. Any doubt so far?
No, thank you.
Okay, then you need to know about this homunculus. Just get a basic idea. You don't need to remember every structure. Okay, Just know that in the very middle part, okay, you're having all the regions below the hip. Okay, below the hip, that means hip and your leg. Okay, it will be control the movement of these areas and the and the sensor areas of and the senses for these areas. It is controlled by the central part of your cerebrum. Okay, the primary this frontal cortex, right, as you can see, and these areas are supplied by the anterior cerebral artery. So whenever a stroke in my anterior cerebral artery happens, either it could be a ischemic stroke or it could be a hemorrhagic stroke, what's going to happen? The blood supply to these areas will be compromised, and as a result, I will get the paralysis of my lower limb. Okay, I will get the sensory loss of my lower limb. Okay, the lateral areas. Okay, first you will have the trunk. Okay, then you will have the hand, and at the very extreme lateral, you will have the face. So whenever a damage to my middle cerebral artery occur, okay, any branch which is supplying this very lateral part, okay, and you can also identify it by the CT or by the MRI. Whenever the CT or the MRI is showing any lesion in a very little part of my brain, that means I'm having an involvement of my face. I will get the all these Bell palsy like symptoms. Okay, I will get the paralysis of my face. I will get a sensory loss over my face. Okay, because as you can see, this lateral part is also supplying my face, right? So just have a basic look that at a very extreme lateral, I'm having the face. At the extreme medial, I'm having the lower limb. And in between, I'm having my upper limb, my head, my hands, my trunk. Okay. They will help you whenever you get any stroke portion or whenever any, whenever they give you any kind of CT or MRI of the patient, they will ask you what symptoms patient can get. Okay. So you need to be able to identify by looking at this homunculus. Similarly, whenever you got any tumor involving this extreme medial area of the brain, what you will get is a symptoms of the lower limb first. You will get the paralysis in the lower limb, episodic paralysis will be there, episodic paresthesias will be there. Okay, very important. Any doubt?
Is there any reason for those episodic symptoms in tumors and other lesions?
You will get permanent also. Sometimes episodic, sometimes permanent.
Okay,
It
so
depends
it's
upon the
just a
tumor.
presenting feature.
Yeah, it depends upon the tumor, the
Okay,
size of the tumor, everything.
right. Okay, thank you.
Okay, then you need to know the distribution of the cerebral arteries. Okay, you have three major arteries: the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Okay, as you can see on the laterally, okay, the anterior cerebral artery supplying all the superficial structure, as you can see, the very superior and the medial part of your brain, as you can see. That means this area, okay, the very medial part of the cerebrum is supplied by the anterior cerebral artery. The lateral part of your cerebrum, which is this part, as you can see also in this figure, it is supplied by the middle cerebral artery, and the posterior part, including the base of the brain, as you can see here. Okay, that means the limbic system and the amygdala, the hippocampus, these are all controlled by the posterior cerebral artery. Is that okay? The base of the brain, major part of the temporal lobe, as you can see, all these areas that include thalamus, subthalamus, okay, the uh, the limbic system also, it is all controlled by the posterior cerebral artery, the primary visual cortex, right? So for the lateral part, the middle cerebral artery, okay, the medial part anteriorly, it is all by the anterior cerebral artery. The posterior part as well as the medial part, including your limbic system, it is all controlled by the posterior cerebral artery. Is that okay?
Yeah.
And look for that also. So this is your caudate nucleus. Okay, and please note that it is not a vertical cross section, it is a horizontal cross section. Okay, so you can also imagine all this structure in the 3D view. Okay, the caudate nucleus coming out of the screen. Okay, this part. Then you have the putamen, the globus pallidus externus, and the globus pallidus internus coming out of the screen. Okay. Then you also have this thalamus, as you can see. Okay, but you cannot identify the subthalamus. Okay, So, and this is the internal capsule, as you can see. This pathway is the internal capsule. All these white matters, all these pathways will run from here. Okay, very important. So on this posterior part, including the thalamus, it is supplied by my posterior cerebral artery. Okay, the lateral part, including my globus pallidus, externus, internus, and the putamen. Okay, as well as my internal capsule, some part, it is controlled by the medial cerebral artery. Okay, you have a separate branch from these carotid arteries. Okay, and this is the anterior choroidal artery. Okay, we will hear that about in a minute later. Okay, and you have this antecerebral artery supplying my anterior part of the brain. Okay, the forebrain, as you can see. Okay, and some part of the internal capsule also, as you can see, involving my caudate nucleus. So the caudate nucleus, a part of my internal capsule, it is supplied by the deep branch of the anterior cerebral artery. Okay, superficial branch supplying the more superficial structures like the Broca's area. Okay, not the Broca's area, it is by the middle cerebral artery, but the more central part, right? And yeah, so that's, you must remember all the locations of different arteries and different structures which are supplying by these arteries, right? It will help them identifying the stroke, the symptom of the stroke, the cause of the stroke, and other things, right?
Yeah.
Okay, so any doubt so far?
No, thank you.
Okay, so we will take a short break and we'll continue the blood supply again, right?
Yes.
Okay, yeah. So any doubt so far up to blood supplies?
No, thank you.
Okay. Then you need to know about the watershed zones. Okay. In a scenario of any acute global ischemia, like any shock, okay, for example, or any, any atherosclerotic plaque in the common carotid artery or the internal carotid artery, like in that case, these watershed areas will get die first, okay, because they receive some blood supply from the terminal branches. Okay. And as you can see, if you make this diagram a 3D one, okay, so let me draw this if I can. If you make this diagram a 3D one, what you will see, let us suppose this is your brain. Okay, this is a cross section. Something like that if you get. Okay, so imagine this is a 3D view of your brain. Okay, and now just a second. Okay, that's all. Now, in a scenario where you get this acute ischemia, any global ischemia, okay, in that case, all these areas, these watershed areas will die first. Okay, and what you can expect is a wedge-shaped infarct first. Okay, and it would be like this kind of a strip we'll see. Okay, yeah, this kind of a strip we'll see. Similarly, on the other side also, you will get to see this strip. Okay. Similarly, on this side, you will see the strip. Similarly, on this side, you will see the wedge-shaped strip. Okay. And that happens whenever you get a global ischemia, not a focal neurologic, but a global ischemia. Whenever you will get these kind of strips. Okay. These strips are always few centimeter lateral to the central line. Okay. And they are always parallel to each other, as you can see. So whenever a question stem describe a scenario in which a patient get a sudden shock or any kind of a trauma in which he is losing all this blood supply from the brain, in that case, you will see that the infarction first happening in case of these strips, okay, and there will be a wedge-shaped infarct like that, okay, and it will be in the form of these strips which are few centimeter lateral to the center line and parallel to each other. I have drawn this diagram, okay, in this 3D view. I hope you guys understanding this diagram. Yes. No.
I can't understand the in the actual diagram, there's anterior and posterior infarcts, but
Yeah,
how do I?
exactly.
Yeah, so how is the orientation of the diagram which you have made?
See, you have the brain and imagine the brain like that, okay. Okay, imagine the brain like that and you cut it like this. Okay, I'm displaying this part here. Okay,
Right. Yeah.
this is the lateral part. As you can see, if I cut this part here from here and I display it like that, okay, so as you can see, all these infarcts, they will run like that all the way to the posterior part. Okay, let me clear all these drawings. What you will see on the laterally, you will see this kind of line formation. Okay, right? Yeah.
Yes. Yes.
And if I cut it from here like that, what I find, the diagram that I draw previously, right? Similar line will be on
Right.
that.
Right.
Similar line will be on that side. Okay.
Yeah. Yeah.
Okay. Great. So that's how you will be. That's how we'll get the question on this watershed zone. It would be a global ischemia first. Okay, the blood supply to the brain should be inhibited at the same time in every part. Okay, and what you will see, these kind of wedge-shaped infarcts. Okay, very much important. You will get these kind of wedge infarct because these are the watershed areas in the brain. You will see that these areas are in the are running parallel to each other. As you can see, they will running very much parallel to each other. Okay, and they will be in the form of strips which are few centimeter lateral to the central line, right? That's how they will describe the question and the MRI of the patient, and then you need to identify that this is the infarction of the watershed area and the patient must be having a global cerebral ischemia, right?
Yeah.
Okay, good. So yeah, that's everything written on this page. Okay. And now comes the circle of wills. Okay, so first we need to know all these branches, okay, which are supplying this circle of valence. Okay, so you have this iota here, as you can see. Okay, first you have the brachiocephalic trunk. Okay, then you have the second branch of the iota, which is the left common carotid artery, as you can see, and then you have the left subclavian artery. The brachiocephalic trunk will be divided into two arteries. The one is the right common carotid artery, as you can see. I zoom. Okay, and the second is the right subclavian. Okay, from these subclavian arteries, you have another branches which are the vertebral arteries, the right vertebral artery and the left vertebral artery. Okay, now the common carotid artery will be divided into the internal carotid artery and the external carotid artery. Okay, and as the vertebral arteries go up in your brain, okay, as you can see, this is the right vertebral artery, the left vertebral artery. They will first give a branch which is known as the posterior inferior cerebellar artery, which is here, right before the joining. They will give up this branch. Okay, posteriorly it will be right, and this branch is known as the posterior inferior cerebellar artery. Okay, then they also give another branch after joining, and it will forms the anterior spinal artery. Okay, and it will run centrally downwards. Okay, it will supply your spinal cord area as well as the anterior part of your brain stem. Okay, then the two arteries will join. and they will give off another branch, which is the anterior inferior cerebellar artery. Okay, it is the anterior to cerebellum, as you can see like that. It will give. Okay, the anterior inferior cerebellar artery. Then after joining, they form one common artery, which is the basilar artery. And this is the basilar artery, as you can see after joining, right? This basilar artery run anterior to the pons, and it will give short pontine arteries, short branches, which are known as the pontine arteries. So like that, they will give short branches. These are the pontine arteries supplying the anterior pons. Okay. Then the final branch, which is the superior cerebellar artery. So you have the inferior, you have two inferior. One is the anterior inferior and the second is the posterior inferior, and you have one superior, which is near the midbrain. It will supply to the superior part of the cerebellum. Okay. And then it will divide into two branches, okay, which are the left and the right posterior cerebral artery. Okay, you have supplied the inferior cerebellum, it has supplied the superior cerebellum, and now it is supplying the posterior cerebral part, which is the posterior or the occipital lobe. Okay, and these branches also supply the midbrain because they are lie very close to the midbrain, as you can see. Okay, so both the midbrain as well as the posterior cerebellum is supplied by these posterior cerebral artery. Okay, any doubts so far?
No, thank you.
As you can see on this diagram also, these are the vertebral arteries. Okay, they are first supplied the posterior inferior cerebral artery, then they join and form the anterior spinal artery running anterior to the spinal cord. Then they give off a branch known as the anterior inferior cerebral artery. Okay, and then the superior cerebral artery. As you can see, they are going upward. They give off some short branches known as the pontine arteries. And finally, this branch, as you can see, the smaller one, if I zoom, right, this smaller one is known as the anterior, the superior cerebral artery. And finally, the two major branches, these are the posterior cerebral artery. Okay, so these are all the blood supply from the posterior circulation, which are by the vertebral arteries. Then you have the anterior circulation, and the anterior circulation is provided by the internal carotid artery. Okay, internal carotid artery gives three branches initially, four branches actually. Okay, one is the posterior communicating. Okay, second are the anterior choroidal. Okay, if you guys go back, yeah, this part of the posterior capsule, okay, it is supplied by the anterior choroidal, and I told you that a separate branch from the internal carotid originates and supply this area, right? So this is the anterior choroidal artery. Yeah. You also have anteriorly two anterior cerebral arteries. Okay, we're supplying the medial structure of the brain. As you can see, this medial part of the brain is supplied by the anterior cerebral artery. Okay, and finally on the lateral side, you have the middle cerebral artery. Okay, the middle cerebral artery gives off some short branches known as the lenticulostriate vessels, and these lenticulostriate vessels supplies the deep structures of the brain like the basal ganglia. The major function of these lenticulostriate of these vessels is to supply the basal ganglia and all the structures which involves the basal ganglia. Okay, like the thalamus, the subthalamus, putamen, substantia nigra pars compacta, okay, and other areas. These are all supplied by the lenticulostriate vessels. Now, this posterior communicating artery, anterior cerebral artery, anterior communicating artery between the two cerebral arteries, okay, and the posterior cerebral artery, they all contribute to the formation of a circle of, which is known as a circle of Willis. Okay, very much important. Any doubt on the circle of Willis?
No, thank you.
Now, in the later pathology section, you will study all these strokes, okay, and you will see, what symptoms, what kind of a stroke happened whenever you got any blockage in the anterior spinal artery, okay, and that means the anterior structures, all these nuclei which are present anteriorly, they will get die. What happens when you get a damage of the posterior inferior cerebellar artery and the anterior inferior cerebellar artery? The posterior structures will die first. What happens when you get a damage in the pontine arteries or the basilar artery, I must say? In that case, your pons will die first. What happens when you get a superior cerebellar artery damage? Okay, and then the posterior cerebral artery, that means your primary visual cortex will die. You will get blindness. You will get a midbrain damage also. Okay, what will happen when you get a damage in the middle cerebral artery or the anterior cerebral artery or the posterior cerebral artery, right? So, for that, you must remember what areas these arteries are supplying. Okay, very important. And then you have one associated syndrome, okay, which is known as a subclavian steal syndrome. Okay, now you're already heard about this this coronary artery syndrome, right?
Yes.
In which when you get a maximum dilation of one of the coronary vessel and you give a patient another vasodilator, in that case the vasodilation will happen to the normal part of the body, of the coronary arteries, right? And as a result, all of the blood go to that normal part, and that ischemic part will become even more ischemic, right? Now, similar kind of syndrome happens in the brain also, and this is known as a subclavian steal syndrome. As you can see, that all these vertebral arteries are the branch of subclavian artery. Right now, in the scenario where you get any stenosis in the, just let me draw it. Whenever you get any stenosis in the subclavian vessel, either the right or the left, okay, as a result, the blood supply to that area will be lost. Okay, the first symptom you will get is the limb ischemia, the claudication, right? You will get the limb claudication whenever you try to move your hand. Okay, because the blood supply to that area will be lost. Now the pressure in that area will be dropping. Okay, you have these vertebral arteries, okay, which are the branches of the subclavian artery. Now what happens normally in a scenario, you have this blood flow moving here, you have blood flow moving here, and it will supply your brain. But in the scenario where the stenosis in the subclavian vessel happen before it gives a branch, this vertebral artery, now because of this stenosis, blood won't be flowing this direction. Okay, the blood will be lost, and because the pressure in that area is dropping, all of the blood from the right vertebral artery, it will go to the left vertebral artery, and then it supplies the subclavian artery. Is that okay?
Yes.
And as a result, you will lose the blood supply to your brain, and what you will get is the syncope, right?
Yeah.
So the etiologies, it includes the atherosclerosis. It sometimes can be happen in the Takayasu arthritis because it affects some major branches of your body, right? So Takayasu arthritis can cause it any kind of heart surgery. Okay, like in case of any reparation of the aorta. Okay, any aneurysm happen and you repair it. Okay, then after the surgery, you can have this kind of stenosis in the subclavian vessel. So as a result, all of the blood will flow from the from the contralateral vertebral artery. Okay, and then it will go into the ipsilateral vertebral artery rather than going to the brain. So what you will get is the first of all the ischemic symptom of the limbs. You will get the claudication, right? Exercise induced pain, you will get fatigue, you will get, okay, you will get the vertebrobasilar insufficiency. Okay, that means you will get the dizziness, you will get the syncope, right? And the test you will perform is a Doppler ultrasound. Okay, and on the Doppler ultrasound, what you will see on the ipsilateral side, that means on the side where the stenosis happened, it will show the retrograde blood flow, which means opposite to my brain, the caudal direction, okay, rather than the anterograde flow, which is this flow towards the brain. Okay, so on the Doppler ultrasound, what you will show is the retrograde blood flow rather than the anterograde blood flow. Okay, and this is the subclavian steal syndrome. Okay, in the FA21, it has mentioned, I think, in the CVS part. Okay, but in the FA 2020, it has not mentioned anywhere, and I studied in the neurology, so I mentioned it here, right?
Okay.
Any doubt on this subclavian steal syndrome?
No, thank you.
And now you have the dural venous sinuses. You don't need to remember every name of every sinus, right? Just get a basic idea that all these venous sinuses running in which layer of the brain?
Subarachnoid space.
No, it was a CSF, which is running in the subarachnoid space, right? It is not the veins. The CSF ultimately get absorbed in these veins, okay, by the
Yeah,
arachnoid granulation.
then yeah, between the dura and the arachnoid.
In between the two layer of the, see, you have two dura matters, okay? You have two layers of the dura matter, okay? And these veins will run in between these two layers of the dura matter, okay?
Okay, yeah.
So first of all, you have the superior sagittal sinus, as you can see, okay, draining all the CSF from the anterior brain, forehead, right? And it will ultimately drain the all this blood into the confluence of the sinus, which receives the input from the infrasagittal sinus and the great cerebral veins of Glen, okay, and then to the straight sinus and finally into the confluence of sinus, okay. Now, you have this transverse sinus supplying the brain again, meeting this confluence of sinus area, and finally all of this blood will go into the internal jugular vein. Okay, you have the cavernous sinus here, which is near the pituitary. Okay, as you can see. So you don't need to remember anything about it. Just know that these are running in the dura mater. Okay, the two layers of dura mater, and all these veins, they're basically draining the blood or the CSF from the subarachnoid space by the arachnoid granulations. Okay, in a scenario where you have any thrombosis in the pathway of drainage of the blood, what you will get is the inhibition of the absorption of the CSF, right?
Yes.
Because if the veins are not draining the blood, then ultimately CSF won't be drained by the granulations, and you will get is the increase in the CSF, and ultimately what you will get is the increase in the intracranial pressure. And because you know that your cranial nerve 2 is nothing but just an extension of the brain, right? It contains all the meninges. Okay.
Yeah.
So the pressure, this increased pressure, will travel through the cranial nerve to the optic nerve, and it will transmit into your eye. And in the eye, what you will get is the edema of the cranial nerve 2, and this is known as the papilledema. Okay.
Yes.
You can also get the focal neurologic deficits. So headache, seizures, papilledema, focal neurologic deficits, these are all the signs and symptoms you will look for the venous sinus thrombosis. And it has happened because of any thrombus in the veins, of course. Okay. And it generally associated with the hypercoagulable state. We have discussed many of them already, the pregnancy, OCP, factor 5 leiden, right? And in the antiphospholipid antibody syndrome also, you can get that, right? So
Yeah.
remember that, okay? Any doubt on this page?
No, thank you.
This is a subclavian stale syndrome we're talking about, right? It is because of a stenosis in the subclavian artery, as you can see, stenosis. And as a result, instead of going to the this anterograde flow, you're getting the retrograde flow like that. Okay, and that will be shown by the Doppler ultrasound, right? Then from the dura matter, okay, we go towards a deep structure, which is the arachnoid matter. And in the arachnoid matter, you have the CSF, the cerebrospinal fluid in the subarachnoid space. And so does all the ventricles are present here. Okay. So first of all, you have the lateral ventricle, and you have two lateral ventricles. We have discussed that already when we're discussing about the cross section of the brain. Okay. And lateral to these lateral ventricles, what nuclei is present?
Caudate.
A caudate nuclei. Yes. So in a scenario where you have any degeneration of the caudate nuclei, like I told you, whenever you have any space in the brain, the ventricles will occupy it, right?
Could you
Yeah.
please repeat that?
Whenever you have any space in the brain due to any kind of degeneration or atrophy, okay, the ventricles will occupy that space, right? The ventricles will expand, right?
Yes.
So in the scenario, if you have any atrophy in the caudate nucleus, and that happens in what disease?
Huntington's.
the Huntington's disease, right? In that scenario, you can have the ventriculomegaly of the lateral ventricles. You will have the hydrocephalus. You will have the enlarged ventricles because of this atrophy of the caudate nucleus. The lateral ventricles will expand. Is that okay?
Yes.
And this is one of the features you will get on the CT or MRI of the patient of the Huntington's disease. Then in the center, as you can see, you have this third ventricle. Okay, all of the blood, all of the CSF will be drained into this third ventricle via duct, okay, or a foramina, not a duct, a foramina, which is known as the foramina of Monro. Okay, and then from the third ventricle, all of this CSF will go into the fourth ventricle, as you can see, which is present just near your pons and the midbrain, just posterior to it, in between the cerebellum and the pons, you will see. Okay, and this CSF will travel to the fourth ventricle via duct known as the what duct? The duct of the cerebral aqueduct of Sylvius, right? Okay. Now, finally, from this fourth ventricle, you have two foramen. Okay, the medial one is known as the foramen of Magendie. Okay, and the lateral foramen is known as the foramen of Leschka. You can remember them by the M in the Magendie and L for the Leschka. L for the lateral, L for the Leschka, M for the Magendie, and M for the median. So in the medial, you have this medial aperture, Magendie. In the lateral, you have this Leschka. From there, all the CSF can go to the spinal cord from the lateral. From the medial, it can go to the subarachnoid space. Okay, and from there, it will absorb into the veins via arachnoid granulations. Okay.
Yeah.
And then into the dural venous sinuses. So this is your ventricular system. Step one can present you a question. They will, ask you about the communicating hydrocephalus and the non-communicating hydrocephalus. Okay. For the non-communicating type, they will give you any obstruction. Actually, they will ask you about the obstruction, right? They will give you that the third ventricles and the little ventricles are expanding. Okay, and so and the fourth ventricle is absolutely normal. So they will ask you, where does this obstruction lie? It must be in the cerebral aqueduct. They will give you a scenario in which you're having the dilation of only the third ventricle, only the little ventricle, not the third one, and they will ask you, where does this blockage lie? So it would be in the foramen of Monro, right? For the communicating hydrocephalus, they will ask you about these arachnoid granulations if the scarring happened, and as a result, the CSF won't be absorbed into the venous sinuses, so you will get the diffuse ventriculomegaly. Similarly, if you have any kind of atrophy of the surrounding structures like the caudate nucleus, right, or or any of the part of the basal ganglia, then you can get the dilation of all these ventricles, right? In case of Alzheimer's disease, you can get a diffuse ventriculomegaly. Okay, so they will present you questions like that, and they will ask you whether it is a communicating or a non-communicating. If it's non-communicating, then where does the obstruction lie? If it is communicating type, then what could be the cause of it? And if the cause is a degeneration, then where does the degeneration lie? Okay, so look for all these questions. Any doubt?
No, thank you.
Thank you.
Okay, now give me a second. Okay, so now this is the ventral view of your brainstem. You're looking from downward, okay, to upward, as you can see. Now, just first look for the pons. Okay, set a reference as a pons. Above the pons, you have four nerves: first, second, and third, and fourth. Okay, the first one is the olfactory nerve. Sorry, okay, and the second one is the optic nerve. Okay, which is present as the optic chiasm, as you can see. This is the optic chiasm of the cranial nerve too. Okay, then you have the third and the fourth. See, only these two nerves are not passing through the brainstem. Rest all of the nerves are originating from the brainstem, except the first and the second nerve. Okay, so your midbrain contain only two nerves. Okay, the third nerve and the fourth cranial nerve. From the pons, you have the exit of the fifth, sixth, seventh, and the eighth cranial nerve. Below the pons, you have the medulla. Okay, and from the medulla, you are having the ninth, 10th, 11th, and 12th cranial nerve exit. Okay, now The even ones, I must say, these motor nerves, those nerves which are only, which are purely motor in the function, like the third nerve, okay, like the fourth nerve, sixth nerve, and the 12th nerve. They are purely motor in the function, and their nuclei lies in the very medial of the brainstem, in the very medial. Okay, those nerves which are mixed type, they are present laterally to these motor nuclei, and those nerves which are sensory, they're present in the extreme lateral part of the brainstem. Is that okay? So in the center you have the motor, in the mid you have the mixed nerve, in the very lateral part of the brainstem you're having the sensory nerves origination, right?
Yes.
Okay, now you need to identify, step one will give you a cross section, okay, and you need to identify, what cross section this is, okay, and not just a cross section, they will point you a structure, a nuclei, and then you need to identify what nuclei it is, and they will go one step further and they will ask you the function or the deficit associated with this nuclei. Okay, so three four things you identify. One is the location, okay, of this cross section. Second is the structure. Third is the function, and fourth is the deficit of this nuclei, right? So let me open a file. Okay, so this is the cross section of the midbrain. Okay, if you refer to the first state, as you can see on the midbrain, okay, um, just give me a second. Yeah. So on the midbrain, you need to identify the location of the superior colliculus. If you look for the first aid, okay, and in the first aid, you have this dorsal view of the brainstem, right? And look for the dorsal view, you have the superior colliculus. You guys can see that in the first aid, the superior colliculus, just below thalamus. You following me, right?
Yes,
Yeah,
In the
yes.
first
but
aid, you can see it there, right? The superior colliculus. Okay.
Hmm.
So if you cross, and if you take a cross section of that area, you will see the superior colliculus here, right? In the center, because anterior to my, posterior to my this midbrain, you have this cerebral aqueduct, right? Because this is a posterior part and this is the anterior part. In the anterior, you have the crus cerebris. In the posterior, you're having the superior colliculus and the cerebral aqueduct. That's how you will identify the midbrain. And if you identify the midbrain, then just go for the algorithm. In the very center, you're having the motor nerves. At the very periphery, at the very lateral, you're having the sensory nerves. And in between, you have the intermediate or the mixed nerves, right? Now, the crus cerebris, okay, they contain all these fibers for your face, okay, all these motor fibers for your face. That means the corticobulbar tract, okay, all of these cranial nerves, all of these nerve fibers which are innervating your face, okay, they will run through this crus cerebris, which are the corticobulbar tract. The corticospinal tract, which is the voluntary motor pathway, it also runs in the crus cerebris. Okay, in the very mid, if you go, right, you have this medial longitudinal fasciculus. We will study the function of this fasciculus later. Okay, so this present in the very center, and you have the origination of the cranial nerve 3. As you can see, this area, this is the cranial nerve 3. Okay, these are all the roots for the cranial nerve 3, because you know that it is very medial, right? Just lateral to it, you can guys imagine about this cranial nerve 4 also, right? It is in the lateral to your this third nerve, right? And out so far,
could you please repeat what you said about the cochlear nerve?
what I said about the
fourth nerve, the trochlear nerve.
See, you have this third nerve here. Okay, this oculomotor nerve, and you guys know that this is a purely motor nerve. Okay, it's present in the very medial. Just lateral to it somewhere. Okay, you also have this trochlear nerve, but slightly lateral, because the trochlear nerve is also a pure motor nerve. Okay, just
Yeah.
okay. So a downwards, somewhat anteriorly, and lateral to my oculomotor nucleus, you're having the trochlear nucleus also. Okay,
Oh, right.
and then you
Thank
have
you.
the red nucleus, and for the red nucleus damage, you need to identify the decorticate and the decerebrate posturing. Okay, you will study that later in the FA. Okay, so just know whenever a damage to this red nucleus happen, you will either get a decorticate posturing, or you will get a decerebrate posturing. Okay, decorticate when the damage happens above the red nucleus, and decerebrate happens whenever a damage happens below the this red nucleus. Okay, are we good?
Okay.
Yeah. Now, in case of a posterior cerebral artery stroke, okay, the midbrain will get damaged, and the central part of this midbrain will die first. You will have the damage of the cranial nerve 3 as well as the cranial nerve 4. For a damage of cranial nerve 3, if you guys remember the function of this nerve, you will get a down and out movement of the eye as a deficit, right?
Yeah.
For the cranial nerve 4th deficit, you will get a tilting of the head also. Okay, we will come to that later. Okay, then for the basilar artery, okay, you will have a damage to the reticular activating system, and this is responsible for your consciousness. If you somehow damage your reticular activating system, you will lose your consciousness completely. Okay, you will also have the damage of the corticospinal and the corticobulbar tract, which is running anteriorly, because the basilar artery, if you guys remember, go back to your first aid and see where this basilar artery runs, just anterior to my pons and the midbrain, right?
Yes.
So when the basilar artery stroke happen, you will have the damage of the reticular activating system, as well as this corticospinal and the corticobulbar tract. Okay, these are the areas you will die first. Okay, these anterior one, the crus cerebralis, I must say. Okay, then look for the location of the substantia nigra pars compacta. Okay, and I told you when we're looking for the cross section of my brain, right? We have discussed that the substantia nigra pars compacta is actually a part of your midbrain, right?
Right.
And what tract run from the substantia nigra pars compacta? The dopaminergic tract.
Striatal
The
pathway.
nigrostriatal tract, right?
Yeah.
And this is responsible for your voluntary movements. Okay. So if the step 1 point to somewhere in the middle, that means they're talking either about the medial longitudinal fasciculus or they're talking about the cranial nerve 3. If they point it anteriorly, that means they're talking about the corticospinal or this corticobulbar tract. Okay, somewhere here, substantia nigra, and in the very dark region, as you can see, a very dark part here, this is a red nucleus. If they mention this red nucleus and they tell you the damage to this part happened, that means you will get a decorticate posturing. Any damage to the, please turn off your mic. Who's this?
Sorry.
Yeah. If you get a damage of the red nucleus or above the red nucleus, you will get a decorticate posturing. If the damage happens below my red nucleus, that means any pons or spinal cord, in that case, I will get a decerebrate posturing. So they will point you somewhere here and they will ask you if a damage to that area happened, what will you find, right? Okay, so look for that. And remember the DCML pathway, the dorsal column middle lemniscus pathway. This is where the middle lemniscus lie, just lateral to the red nucleus. You will find the middle lemniscus. Okay, and if you go from this midbrain to my medulla, you will see that this middle lemniscus is actually like that. They're kind of crossing each other. Okay, so first I have them in the very middle. Then at the pons, I have the crossing over. And after the pons, these structures become lateral. Okay, so going from medulla, okay, to my midbrain, I will find the lateral location of this middle lemniscus. Most medial in the medulla, then a slightly lateral in the pons, and a very much lateral in the midbrain. Is that okay?
Yes.
And please note that this DCML pathway is responsible for your proprioception. Okay?
Yeah.
Very important. In case of any prenuloma, or you have the pineal gland which is present just above your superior colliculus in the middle here, you have the pineal gland. And whenever you got any prenuloma, okay, that means a tumor of the pineal gland, what I will find a compression of my superior colliculus. Okay, and the superior colliculus is responsible for my sight. Okay, so the lateral geniculate body and the superior colliculus, they're responsible for my sight. In that case, I will lose the sight. Okay, and what I will find is the vertical nystagmus. Okay, my vertical movements won't be present. Is that okay?
Yeah. Okay. Cool.
And that happens in the and that happens in the prenuloma. Okay, very important. The inferior colliculi, which is present just below my superior colliculi, they are responsible for the anyone know?
Hearing.
For the hearing. Okay, just like my lateral and the middle geniculate body. Okay, so all the fibers from my periphery, okay, and they will run through this the brainstem first, okay, from the inferior or the superior colliculi, and then from the inferior and superior colliculi they will go to the thalamus, to the lateral or the middle geniculate body, and then they will go to my respective locations in the cortex. Right, that's how the fibers run. If you guys try to imagine that. Okay, so any doubt on the midbrain?
No, thank you.
Okay, then you have the cross sections of the pond. If you look for the first state and see the brainstem ventral view, you will find these kind of structures in the anteriorly. Right? Yeah. Let me open the first state so that you will have a better understanding. Yeah. See this bulginess, this part, right? Yeah.
Yes.
Yeah, this part. Okay. This part would be anterior, right? And if you look again, as you can see, that my fourth ventricle is present just below my pons. Oh, sorry, just behind my pons, and this pons, right?
Yeah.
So in the anterior, I have this kind of bulginess. In the posterior, I have the fourth ventricle, and that's how you will identify the pons in the question. Okay. So if I go back again to the file, this is the anterior part. Okay. And this is the posterior part. As you can see, this is the cavity of the fourth ventricle, and this is the anterior structures. And just like my midbrain, okay, the crus cerebrales were there, you know, and they contain the corticospinal and the corticobulbar tract. Similarly, in the anteriorly, I have the corticospinal and the corticobulbar or the corticonuclear fibers, right? These structures, they are the corticonuclear and the corticobulbar tract. Sorry, the corticospinal tract. In the varimate, I have all these motor nuclei, and from the pons, you have 4 nerves origin: the 5th, 6th, 7th, and the 8th nerve. Okay, and only the 6th nerve is the motor nerve among them, right?
Yeah.
Yeah. So in the very middle, you have the nucleus for the cranial nerve 6. Okay, and this nucleus lie in a very close association with the PPRF, parapontal reticular formation, and the medial longitudinal fasciculus, just like my cranial nerve 3. Okay, because this area need to be need to coordinate with my cranial nerve 3 in order for a gaze movement. That's why you need a very close association between the MLF and the cranial nerve 6 and the cranial nerve 3. Okay, so these are present in a very medial location. Then slightly lateral to it, you have the nucleus of my 7th nerve, 8th nerve. Okay, and these are the nucleus which originates from my pons. Okay, in a very lateral, not a very lateral, you have this motor nucleus of the trigeminal nerve, and this is a sensory nucleus of the trigeminal nerve. You don't need to remember that, don't worry. Okay, just know the location of the cranial nerve 6. Slightly lateral to it, you will have the 8. Okay, and anterior to it, you will have the 7th nerve. Okay, in a very anteriorly, as you can see, this is the location of the medial lemniscus. And note that the medial, this medial lemniscus in the pons is medial, but in the midbrain it was lateral, right? I hope you guys appreciate that. And you have this spinothalamic tract, which is a sensory tract, which is present just lateral to my medial lemniscus, right? This slight region. This is the spinothalamic tract. Okay, so identify the MLF first, the cranial nerve 6, okay, which is in this central part. Slightly lateral, you have the cranial nerve 8. Slightly anterior, you have the cranial nerve 7. In a very interior, you have the medial lemniscus pathway. Just behind it, you have the spinothalamic tract. In the very anterior, you have the corticospinal and the corticobulbar tract. Now comes the associated lesions. In a PPRF lesion, you will have the damage of the ipsilateral cranial nerve 6 and the contralateral cranial nerve 3. Okay, because after the activation of this PPRF, I can have a gaze movement, and this MLF is required for the gaze movement. The PPRF will activate the cranial nerve 6 and it will activate the MLF. The MLF will activate the contralateral cranial nerve 3. Okay, so the function of the PPRF is to actually activate my ipsilateral cranial nerve 6 and the contralateral cranial nerve 3. Is that okay?
Yeah, yeah.
And eyes will look opposite to the lesion. Okay, because a function of the cranial nerve 6 is to cause contraction in which muscle?
LR.
Yeah, in the lateral rectus, right? So if it is a medial PPRF, then it will cause activation of the if it is a right-sided PPRF, it will cause the activation of right-sided CN6, and as a result, the contraction of the right-sided lateral rectus will happen. So what it will cause is the ipsilateral eye movement. So whenever damage to this lesion, whenever a lesion happens in the PPRF, the eyes will look opposite to the lesion. In case of basal artery, which is running, basilar artery running here, okay, if the damage happens, first you will get the damage of the corticospinal and the corticobulbar tract. You will get the central lesion also. You will get a damage of the cranial nerve 6. Okay, and associated with that, you will get damage of the medial lemniscus and the PPRF also, right? And that is known as the locked-in syndrome. Okay, because all of the 4 limbs will become paralyzed. Your eyes will become paralyzed. You cannot move your eyes. You cannot move your limbs. Okay, all you can do is feel something. You can still feel something, right? Because as you can see, the spinothalamic tract is still intact because it is most posterior, right? This is posterior, and the basilar artery by the pontine branches is supplied this part. This part will die because of that, right? So basically 7th nerve, 8th nerve, and spinothalamic tract will still be preserved. Okay. Are we good? Should I repeat it again?
Yes, please.
See, you have 2 arteries. Okay. One is the basilar artery supplying the anterior structure of my pons. Okay. Then for the posterior structure, you have the posterior inferior cerebral artery and the anterior inferior cerebral artery. Is that okay up to here?
Yes.
If any kind of embolus, or I can say any stroke happens to your anterior part, to this artery, the basilar artery, okay, then this region is supplied by the basilar artery. Okay, this region is supplied by the basilar artery. This region will die. That contains the corticospinal corticobulbar tract. Okay, it contains the medial lemniscus. Okay, it contains the cranial nerve 6 as well as the MLF.
Yeah.
Okay.
Yes.
And whenever the posterior stroke happens, In that case, you will get a damage of the cranial nerve 8, cranial nerve 7, and the spinothalamic tract. Okay, this area will die in the posterior lesion, and this area will die in the anterior lesion. Okay.
Yes.
So if the basilar artery can get damaged, I will get the damage of the cranial nerve 6, corticospinal, middle lemniscus, and the PPRF. Okay. Now, in the lateral pontine syndrome, that happens because of an anterior inferior cerebral artery damage. You can have the damage of the spinothalamic tract, cranial nerve 5, 7, 8. Okay, and the cerebral peduncles will also die. Okay, because you know that this anterior inferior cerebral artery or the posterior inferior cerebral artery, it is also supplying the cerebellum, right? So whenever a damage to these arteries happen, it will also cause a damage in the cerebellum. So you will also get the ataxia, right?
Yes.
And the sympathetic fibers, they also run near that structures very laterally. Sympathetic fibers run very laterally also, right? These are the peduncles, the cerebral peduncles, and the sympathetic fibers will run very laterally. You will also get the damage of these fibers, and that causes the Horner syndrome. Okay. So for the lateral pontine syndrome, that happens because of any stroke, okay, or an ischemia due to the anterior cerebral artery and the inferior cerebral artery. What you will have is the spinothalamic tract damage, and as a result, the senses will suffer. The contralateral sensory loss will happen. You will get a damage of the cranial nerve 5. The senses of your face will be lost. You will get a damage of 7th nerve. Okay. 8th nerve, you will get the dizziness, vertigo, nystagmus, right? For the cerebral peduncle, you will get the ataxia. Okay, for the for sympathetic fibers, you will get the Horner syndrome. These are the symptoms for the lateral pontine syndrome. Is that okay?
Yeah, it's okay.
For the anterior pontine, you will have the basilar artery stroke, and that will cause the locked-in syndrome. You will have the paralysis of all 4 limbs as well as the eyes. Okay. So and not for this stroke only, for any stroke, whenever you have any anterior stroke, the muscles will suffer. And whenever you have a posterior stroke, the senses will suffer. Okay.
Yeah, yeah.
This is a general rule you must remember. For the anterior lesion, the motor will suffer. For the posterior lesion, the senses will suffer. So as you can see, for the posterior lesion, all the sensory nerves, the 7th, 5th, 8th, they will suffer first. Cerebellum, the sensory part, will be suffer first. Spinothalamic sensory suffer first. For the anterior, the muscle part will suffer first. Okay. Now, after the pons, you have the medulla. Okay, the lowest part, and as you can see, the middle lemniscus is in the very middle. Okay, and as you go from the medulla to the midbrain, you have the lateral diversion of this middle lemniscus, right? So these are the middle lemniscus, and below the pons, you have the 9th, 10th, 11th, and the 12th nerve, and they originate from the hair. And because the 12th is a motor nerve, okay, the hypoglossal, it is the most medial, as you can see. Okay, the MLF, just like in my midbrain, just like in my pons, it is again a medial structure in my medulla also, as you can see, right? In the very interior, I have the pyramids that contains the corticospinal fibers and the corticobulbar fibers. Okay, as you can see, the origination, the nucleus of my hypoglossal nerve is there, and the fibers run like that. As you know, you can see that these are the fibers from the hypoglossal nerve originating from here. Okay. Now you also have the vagus nerve here. Okay, and please note that the fibers of the vagus nerve are very important. Okay, for the FA 2020, you need to go for the page number 506. Open it, please. Done. The page where the cranial nerves are mentioned. Please open it. Are you guys there?
Yes.
So you opened it.
Yes.
Okay, now look for the vagal nuclei. There you see three vagal nuclei: the nucleus tecta solitarius, the nucleus ambiguus, and the dorsal motor nucleus. Yeah. So now this is the nucleus tecta solitarius. Okay. And this nucleus tecta solitarius, the darker structures are very demarcating ones you can see here. Okay. These are responsible for the visceral sensory information. That means information from your GI tract, okay, from your tongue, okay, from your baroreceptors. All of these inputs will travel to the nucleus tecta solitarius. If you guys go back to the CVS lecture, we have discussed about the aortic and the baroreceptors and the carotid baroreceptors. And I told you that all of these impulses will be sent to the nucleus tecta solitarius, right?
Yes, yes.
And this is the center of this medulla where the all senses will go first, okay, for the assessment, right? And this is the same nucleus tecta solitarius which is responsible for one of the tract in the dopamine neurons, and this is the mesocortical and the mesolimbic tract. Sorry, the two tracts, the mesocortical and the mesolimbic tract, they also originates from the nucleus tecta solitarius. Oh, sorry. Okay.
Okay.
So this is a very important nucleus. Now, once the information traveled here, okay, and the midbrain, your brainstem has assessed it, okay, now it need to send signal back, and the signals will be sent by the vagus nerve again. For example, let's take the example of the carotid and the aortic baroreceptors, okay. They will send the signal via the cranial nerve 10th and the cranial nerve 9th to the nucleus tecta solitarius. The information received here, okay, your medulla will assess the information. And what happens after, let's suppose if it is a fall, if it is a rise in BP and the stretch happened, signal received here, and then you need to activate the parasympathetic system by the vagus nerve. You guys following me, right?
Yeah, yeah.
And then these, and after that, okay, the signal will be transmitted by the dorsal vagus nucleus, okay, which is this part, and this is the motor nucleus of the vagus nerve. Information received here and the output given to this nucleus where the vagus nerve is originating, and now this nerve will go to my heart. It will cause a bradycardia. It will go to my other organs, causing the vasodilation there, causing a drop in the BP, right?
Right.
So basically this nucleus supplying the parasympathetic innervation to my heart, lungs, upper GI, okay, and other areas. So whenever you heard about the parasympathetic output of the vagus nerve, you will always think about this nucleus, which is the dorsal vagus nucleus. It is present very dorsally, very posteriorly. As you can see here, this is the floor of the fourth ventricle, okay, and this is your anterior part. Now, third nucleus you have is the nucleus ambiguous, okay, and this nucleus gives the motor innervation to my pharynx, larynx, and the upper esophagus. That means upper part of your mouth, okay, for the chewing, for the swallowing of the food. All of these impulses will be given by the nucleus ambiguous. Okay, so these are the three nucleus of my vagus nerve. Is that okay?
Yeah.
And the nucleus tecta solitarius, it has the nerve 7th, 9th, and 10th. Okay, the 7th nerve will be giving the taste impulses to that area. 9th and 10th nerve will be giving the baroreceptor impulses to that area as well as the taste impulses to that area, right? Nucleus ambiguous, it has the 9th, 10th, and 11th cranial nerve, okay, and that causes a swallowing movement of your food. For the this dorsal motor nucleus, you're having the cranial nerve 10th, giving the parasympathetic output. So whenever you heard about the parasympathetic output, you will always think about the dorsal motor nucleus. Whenever you heard about the chewing or the swallowing of the food, you will always think about the nucleus ambiguous. And whenever you heard about this baroreceptors or the aortic receptors or the taste, you will always think about the nucleus tectus solitarius. Any doubts so far?
I have one question.
Yes.
Since the 11th is a spinal accessory nerve,
Yes.
is the it's originating from the spinal cord as well as the brainstem, right?
Yes. Yes.
So the spinal part is basically coming from the nucleus ambiguous for the 11th nerve.
And no, actually, it's not like that. Spinal part originating from the spinal part only. It's not like it is
So
originating from the mid.
I'm talking about the cranial part, the upper part, medulla.
Yeah, exactly.
Okay, yeah, got it. Thank you.
Okay, now see, the anti. Let me annotate it. Now the anterior blood supply. Okay, it will be supplying these areas, the hypoglossal nerve and all this part. Okay, this is under the anterior circulation. Okay, and rest remaining part is in the posterior circulation. Is that okay? Up to here.
Yes.
Now, the anterior, this part is supplied by the anterior spinal artery, okay, and the posterior part is supplied by the posterior inferior cerebellar artery, the pica, okay.
Yeah.
Whenever you have any blockage in the anterior spinal artery, that means a stroke in the anterior part, what you will have is the corticospinal, corticobulbar symptoms, that means the motor symptoms again. You will have the damage of the hypoglossal nerve, again the motor. You will have the damage of the middle lemniscus pathway, that means the proprioception. So like I told you, whenever you have the anterior damage, the motor suffer first. Whenever you have the posterior damage, what you will have is the spinothalamic tract damage. As you can see, this is spinothalamic tract. Okay, all this part will die. You have other nerves like the 10th nerve, okay, like the 9th nerve, and some of the 8th nerve also. 11th nerve, they will suffer in the this posterior inferior cerebral artery stroke. Okay,
Yeah.
so what symptoms I can get? I have two syndromes. One is the medial medullary syndrome, and second is the lateral medullary syndrome. The middle medullary syndrome, it has because of the anterior spinal artery, you will have the corticospinal, corticobulbar tract, the middle lemniscus, and the kidney of 12th. For the lateral medullary syndrome, you have the spinothalamic tract, kidney of 5, 8, 9, 10th, and 11th. So as you can see that these nerves are also, see, the 8th nerve, 5 nerve, okay, these nerves are also common for my pons, right? The posterior part of my pons,
Yeah.
right? So, and the Horner syndrome is also common for my pons. The spinothalamic tract is also common for my pons. The spinocerebellar tract is also. So, all the symptoms of the lateral medullary syndrome can mimic the pontine syndrome also, the lateral pontine syndrome also, right?
Right.
So, the only thing that will help you determining is the presence of the lesion with the 9th and the 10th nerve. And the 9th nerve is supplying the tongue and the pharynx part. So, you get a dysphagia, you will get a loss of sensations, the tongues, right? And because a 7th nerve is present in my pons, so because of that 7th nerve damage, I can get a loss of taste sensations in the anterior two-third, right?
Right.
So whenever you heard about the loss of sensations of the anterior two-third, think about the lateral pontine syndrome, and that's why you will have a blockage in the anterior inferior cerebellar artery. Whenever you heard about the dysphagia, because the 10th nerve is responsible for the this swallowing function, right? And the loss of senses in the posterior one-third, okay, and the deviation of your uvula also, you will think about the damage in the pica, right? The little medullary syndrome. Is that okay?
Yes.
Rest all the symptoms, the vertigo, nystagmus, loss of senses from my face, right? And these are all very common in both my pons as well as the medulla, the lateral part. Okay, so these 2-3 symptoms will help you identify the cause. Okay.
Yes.
Then you have the nucleus we have discussed, all these 3 nucleuses, right? So nothing too much. So the 5th nerve, 8th nerve nucleus has both in the pons and medulla. The pons and medulla lesions can only be differentiated by the 7th, 9th, and 10th nerve involvement. Okay. So we have covered all these nerves. Let's go back to the first stage and see. Okay, so we have covered all these nerves. Okay, as you can see, let's study them again. This is the first nerve, the olfactory. The second is the this optic nerve. Okay. Third is the oculomotor. As you can see, very medially it is originating in the midbrain, right? Then you have the fourth nerve, and please note that the fourth cranial nerve is the only nerve, okay, that decusates immediately. That means whenever a lesion happened, it always a contralateral symptom. Okay, like if I draw my midbrain, this is my midbrain, right? And let's suppose this is a nucleus of my fourth cranial nerve. Okay, now this is the anterior, sorry, this is the posterior, this is the anterior. What happens as soon as it originates, it decusates. Okay, like this. Okay, and that's how the right-sided fourth nerve nucleus supplying the left side, and the left-sided fourth nerve nucleus supplying the right side. Is that okay?
Yeah, and do they originate from the posterior side itself?
Sorry, pardon, please.
Do they originate from the posterior side?
Yeah, from the posterior part,
Okay.
very medially, posteriorly, very medially. Okay.
Okay, yeah. Thank you.
Okay, so this is the only cranial nerve that get decusates, and that's why the lesions will be always contralateral. Okay, so lateral to it, because all of these sensory nerves or the mixed nerves, they will be lateral, and all of the motor nerves are medial, as you can see, right? These are all medial. So you have this fifth nerve, and you can identify the fifth nerve because it has three branches, okay, supplying the areas of your head. Okay,
Yes.
then you have in a very center, as you can see, this is a sixth nerve. Just lateral to it, you're having a seventh nerve. Lateral to it downwards, you're having the eighth nerve, as you can see. Lateral to it downwards, you're having a ninth nerve. Okay, if I go, yeah, this is your ninth nerve. Lateral to it downward, you're having a 10th nerve. Okay, and then in a very low, you're having the 11th nerve. Okay, this is your 11th nerve. Okay, right, and this is your 12th nerve. Okay, in a very medial, again, as you can see, lateral, and then you have the very motor nucleus again, which is a medial. So on the exam, they will give you a gross specimen of the brain, a picture, and they will mention they will arrow a nerve there, and they will ask you to identify that nerve. They will ask you what symptoms could be associated with this nerve damage. So for that, you need to be able to identify. So for for the brainstem, just look for the central part, which is a fourth nerve, and then go laterally counting each nerve: the fifth, sixth, seventh, eighth, and ninth. Finally, after the ninth, you have this. Up to the 10th. Then you have the 11th. Okay, and then you have the 12th nerve here. So fifth, sixth, seventh, okay, eighth, ninth, 10th, 11th, and the 12th nerve. Okay. Any doubt?
No, thank you.
As you can see on the posterior part, you have this pineal gland there, and just behind it, below it, you have this superior colliculi and the inferior colliculi. Above that, you have the thalamus. Below the thalamus, you're having the subthalamus. Okay, didn't mention them here. You have this fourth ventricle, and that's why the pons will be very much open from behind, right? You have the medulla then. Okay, and as you can see, this is the floor of the fourth ventricle that I have mentioned in the cross sections also, right? The floor of the fourth ventricle will be visible in the medulla. Any doubt on that page?
No, thank you.
Then let's, as we have discussed already in the embryo section, the alar plate forms the sensory, and the basal plate will form the motor. The motor will be medial, and the alar plate, which is sensory, will be lateral, right? In the midbrain, you have the third and fourth nerve nuclei, pons, fifth, sixth, seven, eight, medulla, 9th, 10th, 11th. Spinal cord, this 11th. Okay, 9th, 11th, 12th. In the medulla, spinal cord 11th. Some part of the 11th will be in the medulla, some part of the 11th will be in the spinal cord. Okay. Yeah. Then again, following that algorithm, which we have discussed, the medial for the motor and lateral for the sensory, you can easily identify all these foramens. Okay. From above to below, okay, we go in the order of every brain, every cranial nerve. In the very interior or very above in this figure, you have the cranial nerve first, the olfactory nerve. Okay. Then you have the second foramen, this one, which is for the optic nerve. As you can see, the optic nerve going there. And along with the optic nerve, you also have the nerves, you also have the blood supply for the eye. And this is the ophthalmic artery. Okay. Then you have the superior, and this is not the orbital canal. Then you have the superior orbital fissure. Okay. And in the superior orbital fissure, you have 3-4 nerves. Okay. First, you have the third nerve, which is just below the third, the second nerve. Okay. This is the oculomotor. Then you have the trochlear nerve. Okay. Fourth. Then you have this. Just give me a second. Yeah. Okay. So you have this oculomotor nerve. Okay. You have the trochlear nerve. Okay. You have this abduction nerve, 6th nerve. Okay. So these are and the first part of the trigeminal nerve. So third, fourth, fifth one, and sixth. These 4 nerves passes through the superior orbital fissure. Okay. In the very medial, you have the third and the fourth nerve. In the very lateral, you're having the 5th and the 6th nerve. Is that okay?
Yeah.
Okay. Then you have the foramen rotundum, ovale, and spinosum. Okay. ROS, rotundum, ovale, and spinosum. Okay. Okay. So for the 5th second, okay, it passes through the foramen rotundum and then exit through the inferior orbital fissure in your skull. Okay. Very important. And then you have this the third part of this trigeminal nerve, okay, passing through the foramen ovale. Okay, so rotundum and the ovale. Spinosum, okay, only middle meningeal artery passes through the foramen spinosum. Okay, no nerve, only the artery. Okay, and whenever this middle meningeal artery got compressed, what you will get is the damaged, not compressed, damaged. What you will get is the epidural hematoma. Okay. Are we good up to here?
Yes.
Okay,
Yes.
so this is the anterior cranial fossa. This is the posterior cranial fossa. And now we are studying about the middle, and now we are studying about the posterior cranial fossa. Okay. Again, going with the same algorithm, in the very middle, you have the motor nerve, which is the only the 12th nerve remaining, right? So this in the very center, you have the hypoglossal canal for the hypoglossal nerve. Okay. Now, you have this auditory canal, or you can say the inferior auditory meatus. Okay, from there you have 2 nerves, the 7th nerve and the 8th nerve. So you just need to go in the order, right? 7th and the 8th nerve passes through the inferior auditory meatus, right? Now in the very center you have the hypoglossal canal for the 12th nerve. In the very lateral you have the inferior auditory meatus, internal auditory meatus for the 7th and the 8th nerve. Remaining of the nerve, the 9th, 10th, and 11th, they passes through the jugular foramen. And the jugular foramen is actually made up for the jugular vein. Okay, you have also the nerves here. Okay, so the 9th, 10th, 11th, okay, these 3 nerves passes through the jugular foramen, this one. Okay, and then you have the foramen magnum, the very central, where you have the spinal cord, and also the spinal part of the 11th nerve. Is that okay?
Yes. Yes.
So again, for the motor, always central. For the sensory, always lateral. Same algorithm everywhere, right? From above to below. In this figure, you will have all the nerves in a sequence. Okay, just need to identify. So any doubts so far on this page?
No, thank you.
No, thank you.
So if you got a jugular foramen syndrome, that means a compression in the jugular foramen because of any tumor mass or maybe due to any hematoma. Okay. Sometimes it can also happen in the mucormycosis also, right? So what you will have is the deficits corresponds to kind of 9th, 10th, and 11th. Okay, and because of this in 9th nerve, you will have a loss of taste, right? Loss of motor function also. Okay. For the 9th and 10th, you will have the loss of gag reflex. You will study that later that the gag reflex is because of 9th and 10th. Okay. Because of 9th and 10th involvement, you will also have a dysphagia. Because of the 10th nerve involvement, you will having a hoarseness of the voice. Uvula will deviate towards the normal side, and you will have 11th nerve that can lead to a paralysis of the trapezius and the sternocleidomastoid, right? You will have a shoulder drop. So these are all the symptoms of the jugular foramen syndrome. You don't need to remember every symptom. You just need to remember that 3 nerves are involved. And if you guys know the function of these 3 nerves, you can easily identify the symptoms, right? Are we good up to here? Or any
Yes.
doubt you want to?
Yes, yes.
Yes.
Okay, now the cranial nerves. First, we have the olfactory nerve, which is for the smell, and it is a purely sensory nerve. It originates in the lateral nuclei. Then you have the optic nerve for the sight. It is again a sensory nerve. Third nerve is the oculomotor nerve. It supplies the middle rectus, inferior rectus, superior rectus, and the inferior oblique. Okay. The function, and does anyone know the function of the inferior oblique? Anyone? Function of inferior oblique?
External rotation.
Intorsion. Yeah.
Oh,
Okay. It was intorsion or extorsion? I'm confusing actually. I think it was extorsion, right? Not intorsion.
I'm not sure about that.
Uh, it was extorsion. Yes. It's for okay. So for the inferior oblique, it was the extorsion. For the superior oblique, it was the intorsion. Okay. No confusion. So what does it mean? Let us suppose you have this eye. Okay. And the orientation of your eye is like that. Let's say. Okay. Now, whenever the inferior oblique muscle get activated, it will cause the extorsion of your eye. That means if it is medial and this is the lateral, it will cause the deviation of eye like that. Okay, so from here, you will get the hair, right? Now, in order to go back to the same position here, where should you tilt your head? In the medial direction or in the lateral direction?
Medial.
In the medial direction. So if this is your face, okay, in order to get a normal eye, you need to tilt your face like that, right? This is your neck. This is the shoulders. Is that okay?
Yes.
Now, in the scenario where you have the damage of your trochlear nerve, which is supplying the superior oblique, that means you cannot get the intorsion. The cranial nerve 3 will overtake and it will cause the extorsion, right?
Yes.
Now, because of that extorsion, you will get a diplopia. In order to counteract this diplopia, in order to resolve the diplopia, the patient will do what? They will tilt their head. Are you guys following?
Yeah.
Yes, yes.
And let us suppose you have 2 eyes here. Okay, because the other eye is absolutely normal, so it will compensate on its own. But this, let's suppose this eye is, and this is your lateral part. This is again the medial, and this is a lateral. Okay, and this is your left. Okay, and this is your right. let us suppose damage to your right side eye occurred. The cochlear nerve supplying the right eye gets damaged. Okay, now as a result, what happens? The extorsion of this eye will happen in this direction, right? If this is a normal position, the extorsion will happen like that. Okay.
Yeah.
In order to compensate, what my patient will do, they will tilt their head in the contralateral direction. Yes.
Yeah.
Yes.
And that is a symptom of my trochlear nerve damage. Okay, the patient will present you with the head tilting in the contralateral direction. Okay, for the diagram, you can go to the UWorld, and UWorld has a very nice diagram for that. Okay, showing the tilting of the head of the patient because of a trochlear nerve damage. Similarly, if you have a damage of the inferior oblique, as a result, the superior oblique will take over and it will cause the intorsion. Let us suppose if this is the head of the patient and this eye, it was in normal position. Okay, the extorsion is lost. I will get the intorsion again. In order to compensate that intorsion, what my patient will do, they will again tilt their head in the ipsilateral direction. Right?
Yeah.
So for the trochlear nerve damage, you will be having a contralateral tilt. For the oculomotor nerve damage, you will be having a ipsilateral tilt. Any doubt?
No, thank you.
Okay, so that is a function of my oculomotor nerve. The superior rectus, inferior rectus, middle rectus, and the inferior oblique. It also causes the pupillary constriction. Okay, you have two nucleus, the motor nucleus and the Edinger-Westphal nucleus. Okay, the Edinger-Westphal nucleus is for the autonomic supply. Okay, and yeah, that's all about it. For the periphery, at the periphery, you will be having this Edinger-Westphal, and the center will be having the motor nucleus. Okay, so whenever the ischemia happened, okay, the motor nucleus will die first, and whenever any tumor happen, it will compress my nerve externally, and that will cause a damage to my Edinger-Westphal. That means the parasympathetic supply. Okay, you guys following me?
Yes. Following.
If this is the nucleus of your cranial nerve 3, in the center you will be having a motor nucleus. In the periphery, you will be having an Edinger-Westphal nucleus, which is a parasympathetic nucleus. Any tumor happen, it will compress first my Edinger-Westphal nucleus, and as a result, I will get the parasympathetic supply loss. Whenever the ischemia happened, the blood supply to that area will be lost. I will get the motor symptoms first. The motor symptoms means all these eye movements, and the parasympathetic function means the pupillary constriction. Okay. The trochlear nerve we have discussed, it causes the intorsion and the downward movement. Then you have the trigeminal nerve. Okay. And for the trigeminal nerve, just give me a second. Yeah. Now it has three branches. Okay, supplying different part. Okay, it has the ophthalmic branch, it has the maxillary branch, and it has the mandibular branch. The ophthalmic branch supplying the forehead and around the eye and in the nose, in the very center of the nose. Maxillary branch supplying my zygomatic bone over the cheeks. Okay, and the upper lip, up to the upper lip supplied by the maxillary. And then you have the mandibular nerve supplying my jaw and the lower lip. So if I draw my face, this is a face of my patient, this is a nose. Okay, this is a nose. These are the eyes. Okay, these are the lips. Okay, so the forehead region and the central part of my nose, this area is supplied by my ophthalmic nerve. Okay, this part up to the, and this part here up to the upper lip, it is supplied by my maxillary nerve. Okay, and the lower part of the jaw, this jaw, as well as the lower part of my lip, it is supplied by the mandibular nerve. Is that okay?
Yes. Yes.
So these are all the sensory supplies. But because you guys know that a trigeminal nerve is actually a motor nerve, okay, so it also has the motor supplies. It causes a dampening of the loud noises by supplying the tensor tympani. Okay, it supplies the tensor tympani muscle that causes a dampening of the loud voices. Okay, so this is a motor function. Okay, and plus it also supplies the somato sensations for my anterior two-third of the tongue. That means all my pain and temperature from the anterior two-third of the tongue will be traveled by the trigeminal nerve. Okay, now let's discuss. Let me go back. Let's discuss the mandibular nerve because it is the most important one among all these three. Okay, now as soon as the mandibular nerve exits, it divided into four branches: the alveolar nerve, the lingual nerve, the nerves to my mastications, and the posterior auricular nerve. Okay. In the anterior direction, I'm having this alveolar nerve. In the downward direction, I'm having the lingual nerve. In a very downward, I'm having a nerve to mastications, and in the posteriorly, I'm having a posterior auricular nerve. And this nerve supplies the area over my temple. Okay. The nerves to mastication, as the name suggests, it supplies the muscles of the mastication. Okay, we will discuss the muscles later, the masseter temporalis and the lateral and middle pterygoid muscles. Okay, all of these muscles will be supplied by my mandibular nerve, and this is a motor function of this nerve. You have the alveolar nerve that exits the mandibular foramen, okay, and it supplies the innervation to my lower teeth. Okay, and then it enters and gives a mental branch which supplies a sensory part over my lower lip and the chin. Okay, so if I annotate, the mental nerve will exit from here and it will supply my lip, okay, and my chin part. Okay, so the mental nerve is a branch of my alveolar nerve. Mental nerve supplying the lip and the chin. Alveolar nerve supplying this lower part of my teeth and the gums. Okay, so if a damage to my alveolar nerve occurred, like during a temporomandibular joint disorder, in that case, I will get the loss of senses from my gums and my lower tooth, as well as I will get a loss of senses from my lips and the chin. Okay, and while performing any dental procedure, you need to first anesthetize these nerves, the alveolar nerve and the mental nerve, in order to get a loss of senses from that area so that you can easily operate. So from the anesthesia point of view, this is also is important. And from the pathology point of view, it is also very much important. The temporomandibular joint disorder you will get. Okay. And then you have the lingual nerve, which supplies the anterior two-thirds of my tongue. Okay. So the nerve block for the alveolar nerve is done at the mandibular foramen. For any dental procedure, you need to do that. Okay. For the chin, you need to inhibit the or block the mental nerve. Is that okay up to here?
Yes.
So these are all the function of my cranial nerve 5, the trigeminal nerve. It supplies a muscle of mastication. It gives the tensor tympani motor branch. Okay, it supplies the sensory innervation to my forehead. Okay, to my cheek areas, to my lower lip, upper lip. Okay, it gives a sensory innervation to my tongues also. Then you have the abducent nerve supplying the lateral rectus. Nothing very much important about that. You have the facial nerve for the facial. Facial nerve is important. Okay, so every facial movement, okay, every expression that you made on the face, it is all because of my facial nerve. It supplies a taste for anterior two-thirds of the tongue, the chorda tympani branch. You don't need to remember the exact name of the branch. Just know that the taste is provided by the facial nerve. The lacrimation and the salivation from the submandibular and the sublingual glands is by the facial nerve. So whenever you tears, whenever you cry, it is a facial nerve responsible for the tears. Saliva from the submandibular and the sublingual glands. Please note that it is not the parotid. Although the facial nerve lie in a very close association with the parotid gland, like if you guys go back to the GI section, we have discussed that in a tumor of a parotid gland, you can get a damage of the facial nerve, right?
Yeah.
So even though it is lie in a very close association with the parotid gland, it does not supply that gland. It supplies the submandibular and the sublingual gland. For the eye opening, you need the oculomotor nerve. For the eye closing, you need the facial nerve. It also supplies the auditory branch, okay, which is to the stapedius muscle, okay, and it basically kind of work as a volume modulation. So whenever you get a damage of the facial nerve, what you will get is known as the hyperacusis. Even a very a very low volume voices will irritate you very much. Okay, you will have an increase in the susceptibility of the sound, and this is known as the hyperacusis that you will get because of facial nerve damage. Why? Because it supplies the stapedius muscle. Okay, so the facial movements, taste, salivation, lacrimation, eye, and auditory. These five are the function of my facial nerve. 1, 2, 3, 4, and 5. Okay.
Yeah.
Then you have the vestibulocochlear nerve for the hearing and for the balance. Okay, just note that the vestibulocochlear nerve, if this is my eye, okay, right side will push the eye towards the left side, and the left side will push the eye towards the right side. So in a scenario where I have, let us suppose, let me notate it. Okay, so this is your one eye. This is your second eye. And this is the left side. This is the right side. Okay, the right side one will pushing the eyes towards the left side, and the left side one will pushing the eyes towards the right side. In a scenario where you have a lesion in the left vestibulocochlear nerve, your eyes will deviate towards this side. Okay. Are we good?
Yes.
And when the eye deviates to left side, the nystagmus will happens to the other side. The corrected position is known as the nystagmus, right? So nystagmus will happen to the contralateral side, which is the right side. You're following me?
Could you repeat, please?
See, nystagmus always happens to the opposite direction of the eye deviation. If your eyes are deviating towards the left side, then your brain somehow know that you're having a misalignment of the eye and they try to correct it. And during the correction, so you have the very slow movement of eyes towards the left side in a case of left-sided damage. And then you have a very rapid correction. This rapid correction is known as a nystagmus. So nystagmus happens to the opposite side, and the eye deviation happens to the ipsilateral side. Is that okay?
Yes. Yeah. Good. Good.
So
Thank
do
you.
note that point also about the vestibulocochlear nerve. Then you have the glossopharyngeal nerve for the taste sensations, for the swallowing, you guys know. Salivation, the parotid gland supplied by the glossopharyngeal nerve. Okay, the carotid body also gives impulses by the glossopharyngeal nerve, right? And the baroreceptors, you guys know. Okay, elevation of pharynx and the larynx are also done by the glossopharyngeal nerve. Okay, the soft palate. Okay, it also supplies a sensory innervation to my tonsils, to my pharynx, and to my middle ear also. Some part of middle areas ear is supplied by the glossopharyngeal nerve, and that's why you have a rapid pain to the middle ear whenever you have any lesion involving the pharynx because of the glossopharyngeal nerve. Okay, whenever I have any lesion in the pharynx, okay, and that irritates my cranial nerve ninth, you can feel you can even feel the ear pain because of that, and that is known as a rapid otalagia. Okay.
Yes.
Then finally you have you have the vagus nerve. Okay, that basically main function is the swallowing, okay, and the voice. Okay, so soft palate elevation is done by it. Okay, the uvula, to keep the uvula in the midline, you need the vagus nerve. Whenever the lesion happens, the uvula will deviate towards the opposite side. Okay, for the talking, you need the vagus nerve because it supplies your voice box. For the cuff reflex, for the gag reflex, you need the vagus nerve. Parasympathetic nervous system, okay, it is also because of the vagus nerve. Okay, for the monitoring of the aortic arch, you need the vagus nerve. Okay, so for the carotid sinus or the carotid arch, you're having the glossopharyngeal. For the aortic arch, you're having the vagus nerve. Okay, Hypopharyngeal, the pharynx region is supplied by the glossopharyngeal nerve, and the hypopharynx region is supplied by the vagus nerve. Then you have the accessory nerve, and they're responsible for the head tilting, okay, and supplying the trapezius and the sternocleidomastoid, okay. For the hypoglossal, they're for the motor innervation to my tongue movement, okay, very important. And just give me a second. You need to also know about all the muscle, all these nerves innervating your mouth. Okay. So for the hard palate, okay, the maxillary nerve supplying the hard palate. Soft palate, sensory one will be supplied by the maxillary nerve, which is the trigeminal nerve. Okay, and the motor innervation is supplied by the vagus nerve. Uvula is also supplied by the vagus nerve. Okay, in the pharynx, which is this region, it is supplied by the sensory and the motor both by the ninth nerve. The motor can also be supplied by the 10th nerve. Esophagus and the larynx and the hypopharyngeal region, it is supplied by the 10th nerve. Okay, the tonsils, which is present just behind your tongue, they are supplied by the 9th nerve. Okay, and the posterior part of the tongue is supplied by the 10th nerve, which you guys already know, right?
Yes.
Yes.
So do note all these nerves which are responsible for the swallowing, for your food movement. Mainly are the 9th and the 10th nerve. 5th nerve only provide the sensory innervation to my hard palate and my soft palate. The motor innervations to my soft palate is by the 10th nerve. Uvula by the 10th nerve, tonsils by the 9th nerve, posterior tongue by the 10th nerve, pharynx, sensory by the 9th nerve, motor by 9th and 10th both, hypopharynx by the 10th nerve, esophagus, larynx by the 10th nerve. Any doubt on the kinder nerves?
No, thank you.
No, thank you.
Okay. We have discussed all these vagus nuclei already, right? And
Yeah.
then you need to know about the temporomandibular joint disorder. Okay. And the reasons can be because of any jaw misalignment. Okay. That happens can be because of any trauma. That happens because of the bruxism, which is a teeth grinding that happen in which sleep phase?
Mm.
I told you to remember that sleep phase, right? For the bruxism.
RA
And
N2.
in N2, right? Okay, you're having a bruxism in the N2. So patients generally have a history of teeth grinding, either sibling or the parents tell you that the patient having a history of any habit of the teeth grinding in the sleep, and that happens in the N2 phase, right? So because of that, you'll be having a hypersensitivity of the mandibular nerve. So you will get a dull waxing vending pain in the jaw. Okay, and that pain, because the nerve is also supplying your ears, that pain will refer to the ears directly. So with any movement of the jaw, like while talking or while eating any food, you will get a very severe pain in the jaw that radiates to your ear. And whenever you hear this kind of a presentation, you will always think about the temporomandibular joint disorder, and that because of the cranial nerve 3. Okay, I myself had this disorder when I was preparing for the step 1. I got this disorder, and it took me around 2 months to recover from that. It has a very severe pain in the jaw while moving, while eating or while saying anything. You will get this pain, and especially while eating, you will get the pain. Okay, so please note about the nerve which is involved. Okay, why it is happening, because of the teeth grinding, because of any trauma, or because of any jaw misalignment. What symptoms you will get? You will get the jaw pain as well as the ear pain. And why ear pain? Because this fifth nerve also supplies the ear. Any doubt?
No, thank you.
And now see, you're having a main problem with the jaw, right? But you're having a symptoms at the ear, the pain at the ear. And that thing is known as the rapid otalagia. Okay. And similar thing can happen whenever you have any problem with the hypopharynx or the pharynx. You can also get the ear pain. And that again because of the rapid otalagia by the 10th nerve and the 9th nerve. Okay, now you have the cranial reflexes. Okay, for the corneal one, whenever you touch something with the cornea, like with a cotton, okay, you will have immediate closure of the eyes. Okay, and so as you guys know that the closure of the eyes is by the seventh nerve and the opening is by the third nerve, right? So the afferent fibers, the sensory fibers are by the ophthalmic nerve, okay, and the efferent fibers are by the seventh nerve. For the lacrimation, again you have the afferent or the sensory fibers by the this ophthalmic nerve, and the efferent fibers are by the facial nerve, which you guys already studied, right? And please note, whenever you have any damage of any of these part, okay, either the ophthalmic part or the this facial part, okay, the emotional tears won't stop. Whenever you get emotions, you will have the tears, right? But the this reflex tears will be inhibited. For the jaw jerk, it is purely the mandibular nerve, both the sensory as well as the motor. Okay, and you normally do not get the jaw jerk in a normal person. You will get the jaw jerk only whenever you have the amyotropic lateral sclerosis. It is a very hallmark feature of the ALS. Whenever they mention about the jaw jerk, please note that you're gonna get a case of the amyotropic lateral sclerosis. For the pupillary, you have the senses by the optic nerve, and for the motor, you have the oculomotor nerve. Okay, whenever you shine light, the optic nerve will get activated. It will send a signal to my Edinger vascular nucleus, and that will cause a constriction of my eyes. For the gag reflex, you have two nerves. Okay, and that is the ninth nerve and the 10th nerve. Okay, and for the cuff, you have only the 10th nerve. Okay, for the gagging, you need two, 9, 10, 10th. For the cuffing, single is enough, the 10th nerve. And please note that it is the internal laryngeal nerve which takes the sensory symptom, which takes the sensory impulses, and the recurrent laryngeal nerves gives the this motor innervation. Okay, so in the scenario, if you guys go back to the endocrine part, we have discussed about the branches of my laryngeal nerve, right? Of my vagus nerve, right? The recurrent
Yeah,
laryngeal
so
nerve, the internal and the external laryngeal nerve, right?
yeah.
And please note, this internal laryngeal nerve run through a groove. And does anyone remember the name?
Is it the pouch, the smuggler's pouch?
Um, no, I don't think so. It was a smoker's pouch. It is a piriform recess. Okay. You there?
Yeah, yeah.
It was a piriform recess. Okay, it runs in the piriform recess. Okay, and yeah, so whenever and please note that the location of this piriform recess is just in the anterior wall of my esophagus. So whenever I have any food impactation here, it can damage my internal laryngeal nerve, and whenever my internal laryngeal nerve got damaged, please note that only cuff reflex will be gone, not the gag reflex, because the internal laryngeal nerve is purely a sensory nerve. Okay, so it cannot affect my gag reflex because in the gag, I need the motor part of my vagus nerve, which is absolutely normal. But in the cuff reflex, I need the sensory part of my vagus nerve, which is the internal laryngeal nerve. Okay.
Yeah, yeah.
Yes, yes.
Okay, so please note for the gag, you need two. For the cuff, you need only one. Okay.
And I checked on Google, the piriform fossa and the smuggler's pouch are the same.
Okay, these are same. Okay, so
Yeah,
you can remember the name. I didn't know about that. Okay. So yeah, it was a piriform recess or a smuggler's pouch. Then you have the mastication muscles. You have four muscles: masseter, temporalis, medial pterygoids, and the lateral pterygoids. All have M in their name. Okay, and the lateral pterygoid is the only muscle, okay, which lowers the jaw. Okay, and rest all the muscles, they will they will cause the closure of your mouth. Okay, and the lateral pterygoid causes the opening in your mouth. all are innervated by the trigeminal nerve. Okay.
Yeah.
So we have completed the cranial nerves completely. And then you have the spinal nerves. You have 31 pairs, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. Okay. Now, in the thoracic, in the cervical region, every nerve exits just above the respective spine. Okay. So, for example, in case of, if this is your C1, for example, okay, if this is your C1, the C1 nerve exits just above it. If this is your C2, the C2 nerve exit just above it. If this is your C3, the C3 nerve exit just before it. Okay. But in the thoracic, lumbar, sacral, coccygeal region, the nerve exit below the respective vertebrae. Okay. If this is my thoracic vertebra, the T1 nerve exit just below it. For the T2 nerve exit just below it. Okay. And why does happen? Because cervical has 8 nerves. So in the last this vertebra, if this is your C8, sorry, if this is your C7, the C7 will exit just before it, and the C8 exit just after it. And so that after the T1 vertebra, you will be having an exit of the T1 nerve. Is that okay?
Yes.
Yes.
So just note, in the cervical region, you having a exit of the nerves just above your corresponding vertebra, and from the thoracic region up to the sacral and the coccygeal region, you will be having an exit below the respective vertebra. Okay. So now you have the spinal cord, and please note that the spinal cord is present, ends at the L1, L2 vertebra. Okay, as you can see, this is your L1 vertebra, this is the L2 vertebra, and the spinal cord ends here. Okay, now because the pia mater runs in a very close association with the brain and the spinal cord, the pia mater ends here, right? And because the subarachnoid space is present between the pia mater and the arachnoid matter, below here, everywhere you can see it is the subarachnoid space. Okay, very important. And and after that you have this chorda equina. Okay, the end part of the spinal cord is known as the conus medullaris, and after that you have all these nerve fibers for the corresponding vertebrae. Okay, the L2, L3, L4, L5, right? And then this S1, S2, S3, S4, S5. All these nerve fibers run from here, and these are known as the chorda equina. You have corresponding syndromes, the conus medullaris syndrome and the chorda equina syndrome. In the chorda equina syndrome, you will be having a lower motor neuron damage only. In the conus medullaris syndrome, because it involves my spinal cord, you can have the upper motor neuron damage also. Okay. Okay. So yeah. So that was about the extent of my spinal cord and the chorda equina. Now, in order to to remove any fluid from my subarachnoid space, okay, that means if I want to do the lumbar puncture, I always need to perform it below my L2 vertebra. That means between my L3, L4, and between my L4 and L5. Okay, so it could be done either at the level between the L3 and L4, because at the L2 you have the ending of my spinal cord, right? So between the L3 and L4 it could be performed, or between the L4 and L5 it could be performed, right? Because you want to keep your spinal cord alive. And whenever they ask you how you can locate these level, so please note, you will always run horizontally, okay, at the highest point of my iliac crest. Okay, the highest point of my iliac crest, you can even feel it with your hands, okay, at your hip. Okay, you can find it there, and from there you can run you can imagine a horizontal line. Okay, and there you will find the L3 and 5 level. Now, what structures you must pass through? One is the skin, okay, then is the fat and the fascia, of course, then is the supraspinatus ligament, spinous ligament, then is the infraspinous ligament, okay, and finally you have the ligamentum flavum, which is the most posterior ligament, okay, which is covering your spinal cord. The posterior ligament covering your spinal cord is the ligamentum flavum. And we have discussed one condition associated with that. Whenever the hypertrophy of my ligamentum flavum happen, what can lead to?
Neuralgia.
Yeah, you can say that is a symptom. Disease name, anyone remember? The old age. If they lean forward, the symptoms will improve. If they extend, the symptoms will get worse.
Claudication.
And not the claudication. I mean, symptom is a claudication, the neurological claudication. Come on, you're forgetting the name. The spinous stenosis, right?
Understood. Okay,
Don't forget the names. The spinal stenosis. If the hypertrophy of my ligamentum flavum occur, it can lead to the compression of my spinal cord. When I got extension of my spinal cord or flexion, whenever I lean forward, that will make the opening very much widened, and as a result, symptoms will be resolved. And whenever I extend my back,
Yes.
the symptoms will reoccur, right?
Yes, yes, yes.
Then you have the epidural space after the ligamentum flavum. As you can see, this is my epidural space. Okay. And if you want to give the patient anesthesia, epidural anesthesia, you need to stop the needle there. After that, you will get a dura mater. Then you will have the arachnoid mater. And then you get the subarachnoid space where you can collect the CSF. If you have the meningitis, if you're suspecting a patient with the subarachnoid hemorrhage, you will always need to collect the CSF from here. Okay. And please note, you first need to lay down this patient in the recumbent or the sitting position to perform the lumbar puncture, so that you can have an opening of all these ligaments. Because if they're in the extended positions, the bones, these spines will be covering the openings, right? So you need to extend your spine so that the openings could be there, right? For that, you need to put the patient in the recumbent position or the sitting position. Okay. Any doubt on this page?
No, thank you.
And this is a cross section of my spinal cord. Okay. And can anyone know if this is a cross section of my cervical spinal cord or the thoracic spinal cord or the lumbar spinal cord?
So either thoracic or lumbar because of the presence of lateral horns.
You can speak one by one.
Thoracic.
Thoracic. Any other?
Either thoracic or lumbar.
How can you identify the lumbar?
Presence of lateral horn.
Presence of lateral horn in the lumbar. Are you sure?
Yeah, I think so, because L2 till L3, I think the sympathetic system does flow out.
But any specific feature of my lumbar, because they are not present in all the lumbars, right? It is only for the L1 and L2 up to.
I'm involved fully.
What after that? How you can identify the lateral? Look for the anterior horns. Okay. If they are large enough, then it is a lumbar. If it is not, then it is a thoracic. For the cervical, you need to look for this lateral one. Okay. This is a hyperextended type. Okay. So cervical would be like that. Okay. That you will see in the cervical. Okay. In case of thoracic, which is this one, okay, you will have this kind of a structure, a very small lateral horn and a very large anterior horn. In case of cervical, you will be having a very large lateral horn and a very small anterior horn. Is that okay?
Yes.
For the lumbar, you will be having a very big lumbar, as you can see, like that. You will be having the anterior horn like that. Okay. That's how you will identify all these cross sections. Okay. So, yeah. So, okay. So this is your posterior column. Okay. These are a posterior column or the dorsal column, you can say. This is a posterior horn. Okay, and there runs all your inputs, whatever inputs you're receiving on the periphery. Okay, any sensory input or the proprioception or any motor input also. Okay, they will all travel back. They will all travel through the dorsal column, right? This lateral horn, as you can see, this is for the sympathetic plexus. Okay, the thoracolumbar division, the T1 to L2 or L3. Okay, you will find this lateral horn also. Okay, it contains all the sympathetic nerves. In the anterior part, you will be having the anterior column, which contains all the the corticospinal tract, which means the motor tract runs here. Whenever you get a damage of this anterior horn, you will have a motor palsy. Okay, you will have the paralysis, right? Just lateral to it, you will be having a lateral corticospinal tract, as you can see. Anterior to it, you will be having an anterior spinothalamic tract. Okay. This is your anterior spinothalamic tract. Posterior to these and anterior to my dorsal column, anterior to my dorsal horn, I will be having the lateral corticospinal tract here. Okay, so the lateral spinothalamic tract in the anterior and the lateral corticospinal tract in the posterior. Okay, in the center, you'll be having a white commissure. Okay, where the fibers, they will be decussate on the contralateral side. All the fibers for the pain and temperature, they will decussate at the contralateral side, and then they will run in these tracts like that. Okay, and the part where the decussates, this is the anterior white commissure. Okay,
Yeah.
so here now. So now, if you can identify if this is a cervical or a thoracic or my lumbar spine.
Lumbar.
This is
Lumbar.
my lumbar. Yeah, exactly. This is my lumbar. As you can see, the anterior horns are very big, large, wide, and right. So these are the posterior columns. Okay, these are my posterior horn, the dorsal horn. Okay, this is my lateral horn for the sympathetic nervous system. This is my posterior, you can say the lateral corticospinal tract. You also have the anterior corticospinal tract, which is a very medial structure, which is for the voluntary movement, of course, just like my lateral corticospinal tract. You have the lateral spinothalamic tract for the for the pain and temperature. And please note, uh, yeah, we will come to that later. So you have the pain and temperature in the lateral spinothalamic tract. Okay. For the sacral, it would be lateral. For the cervical, it would be medial, which makes sense. All of the fibers which are lateral will be first, which are below will be running in this direction. Okay. And the fibers from the center will keep on adding. Okay. So the cervical one, also, the fibers from the superior will keep on adding in the middle side. Okay. And the fibers from the middle from the below, okay, will be going in the lateral direction. So sacral for the lateral, cervical for the middle. You'll be having the anterior spinothalamic tract, and that is for the crude touch and pressure. See, for the fine touch, you have the DCML pathway. For the crude touch, you will be having a anterior spinothalamic tract pathway. Is that okay?
Yeah.
Now for the DCML, the dorsal columns, okay, we're having two nucleuses, the nucleus gracilis and the nucleus cuneatus. Okay, cuneatus is for the upper body and the gracilis is for the lower body. Okay, the gracilis is in the middle and the cuneatus is in the lateral. So all of the fibers from the upper limb, they will be adding in the lateral direction, and the fibers from the below will be running in the middle direction. So up to the thoracic level, okay, where I do not have any innervation for my upper limb, I will have only this medial column, not the lateral column. From the thoracic level, okay, where my limbs, upper limb join to that part, I will have both the middle column and the lateral column, which means a nucleus gracilis as well as a nucleus cuneatus. Is that okay? And that level is T5. So below T5, I have only nucleus gracilis. Above T5, I have both the gracilis as well as the cuneatus. Are we good?
Yes.
Okay, so yeah, that would be all on this page. Any doubt? You can ask.
No, thank you.
And finally, you have tracts, two tracts. One are the ascending tract and second is the descending tract. Descending tract happens whenever you want to send signal from the brain to my peripheral nerves. And that signal will be from the motor neurons for the motor nerves, right? So whenever my cortex wants to send signal from my brain to my muscles for any contraction, that would be by the descending pathway. Whenever I want to receive any input, that means for any senses like the proprioception, pain, temperature, touch, pressure, anything, it will be in the ascending pathways, right? Yes. Now, if you again go back, the corticospinal tract pathway, which is this one, okay, this is a descending pathway. And my spinothalamic tract and the DCML pathway, these are the ascending pathway. So what happens, let us suppose you have a limb here, okay. For any sensory input like pain and temperature, okay, they will first travel through my ipsilateral area. Okay, this is the left side of my body and this is the right side of my body. And this is my left limb, let us suppose. The fibers from this left limb will travel and they will enter into the left dorsal horn. Okay, and you have the cell bodies lie here. Okay, you have the cell bodies here. They will travel. And now what happens, as soon as they enter that area, they will decussate. They will synapse first. Okay, and as soon as they get synapse, these fibers will decussate and they will come to the opposite side. And as you can see, that happens just anterior to my central canal. So whenever I have any expansion of the central canal, I can damage that area, right? Okay, so decussation happens and then they reaches to this lateral spinothalamic tract and they run upwards then in this tract. Is that okay?
Yeah.
Yes.
So because the cell bodies, as you can see, synapse is occurring in that part, in these horns, because cell bodies lies here, this part appears as gray. And because the axons are running here, which are myelinated, this part appears white. Okay. This is about my lateral spinothalamic tract for the pain and for the temperature. Okay, so first synapse happen in the spinal cord only, and as soon as the synapse happen, they will decussate and they will go in the spinothalamic tract. Now, what about the proprioception? Now, for the fine touch, for the pressure, okay, and for the proprioception, that means the position sensing. Okay, the sensory inputs will run. They will similarly enter into my spinal cord via the dorsal column. Okay, cell bodies lying in the ganglion outside. Okay, but instead of synapsing, these will go run into the dorsal columns. They do not get synapse. Instead, they run upward in the dorsal column in my spinal cord. Is that okay?
Yeah.
In the ipsilateral direction only, right? Now you have the motor inputs. The motor inputs will be traveling from my cortex. This is my cortex. Okay, and let's suppose this is my uh, right side and this is my left side again. Okay, inputs from my right side, let's suppose. So it will go and in the medulla, okay, they will kind of decussate. Okay, the upper motor neuron in the medulla, they will decussate. Okay, and they will run in the opposite side, in the opposite part. Okay, and this happens in the medulla. Okay, now then they run in the downward direction in the anterior horn. Okay, these anterior horn, they contain the upper motor neurons. In the anterior horn, I will be having the synapse. Synapse happen in the anterior horn, and then I have this. Oh, sorry, not in the. I'm sorry about that. Just give me a second. Misconfusion happened. Yeah. So the cross section. Sorry, the decussation happens in the medulla. they run opposite, and they run in the posterior corticospinal tract. Okay, this is a white matter, right? They runs here, then at the level of my muscle, they will enter into the anterior horn. From there, they will get a synapse. Okay, and then this lower motor neuron from my anterior horn, it will go to my respective muscle. Is that okay?
Please repeat.
See, you have the cortex, okay, and you want to flex a muscle group, let us suppose, okay, like your arm. Signals will be originate from the cortex. They will travel down into the internal capsule, which we have discussed already, supplied by what artery? Internal capsule.
Anterior and middle.
No, it was the anterior caudal artery, right? So should I go back and tell you guys where the, let me go back for a better clear understanding. So yeah, these are your posterior capsule, right? This part is a posterior capsule, and all these sensory fibers, all these motor fibers, they run through here, right? Okay.
Yes.
So whenever any signal originates from the cortex, they first run through my these internal capsule. They will reach to the thalamus. From thalamus, they will run down into the now. From thalamus, they will run down into the corticospine. This tract, the corticospinal tract. Okay, this part, right? And now this is the first degree neuron only, right? Synapse hasn't occurred anywhere in this pathway. Now, at the muscle level, let us suppose at the level of my upper limb, that means my cervical and the thoracic level, these nerves will enter into the anterior horn, and there they will synapse. Okay. After synapsing, the lower motor neurons originate and they will supply this nerve, sorry, this muscle. Okay.
Yeah. Yeah.
So the signal for the left-sided muscle contraction will originate into the right cortex, and the signal for the right-sided muscle contraction originate in the left cortex. Whenever I got a damage of my lower motor neuron, okay, I will get an ipsilateral symptom. Whenever I get a damage below my medulla, anywhere below my medulla in the upper motor neuron, I will get an ipsilateral symptom. Is that okay?
Right.
But above my medulla, because a decussation happens, I will get the contralateral symptoms. That means if I damage my cortex, like in case of ALS or in case of any stroke, I will get the contralateral symptoms.
Yeah.
Good.
Okay.
So now any doubt?
No, thank you.
Now
No,
with these
thank you.
things in mind, let's discuss the pathways again. Okay, so the nerve impulses for the pain and temperature. Okay, lateral for the pain, temperature, anterior for the croup touch and deep pressure. Okay, the first degree neurons will originate from the sensory endings, which we have discussed, the Ruffini corpuscles, the Markle discs, and other. Okay, and the fibers will be A delta fibers and the C fibers. Remember, the A alpha fibers are the fastest. Then you have
Yes.
A delta, and the slowest one are the C fibers, right? They originate. Okay, they will bypass pseudo unipolar cell body in the dorsal root ganglion. Okay, which is again, the neuron which is supplying your sensory areas. Okay, these nerves. Okay, then it will enter the center spinal cord. It will enter the spinal cord. Within the spinal cord, it will get a synapse. Okay, in the ipsilateral gray matter, and from the synapse, this the second order neuron will decussate, and it will go into the contralateral side and then run upward or ascend upward in the contralateral direction via spinothalamic tract. Is that okay? The second order neuron that forms after synapse, right? Now
Yeah.
it runs and then it reaches a thalamus. The VPL, you guys remember the ventral posterior lobe for the all inputs from my body, right?
Yeah.
It will reach there. It will synapse again in the thalamus. And from the thalamus, the third degree neuron will originate. Okay. And this third degree neuron will go to the cortex. And where does it go? Into the sensory cortex, the primary somatosensory cortex, which is present just behind my central sulcus. Okay.
Yes.
Second, for the DCML pathway, it is for the pressure, vibration, fine touch, proprioception. Again, the sensory innervation starts by the first order neuron. Okay, the cell body of this neuron lies in the ganglion. Okay, it will enter my spinal cord, but it do not synapse there. What happens? It will run in the nucleus gracilis, in the nucleus cuneatus, upward. At the level of medulla, it will have the synapse in the medulla. Within my medulla, it will have the synapse, and then it run contralaterally. It will ascend contralaterally, and that's how you know that in the medulla, the DCML is very medial, and after the medial, because it have to run contralaterally, okay, it will become lateral. If you guys note the position of my medial lemniscus in the medulla, it was very medial, and as I go above in the midbrain, it will become lateral, right?
Yes.
Yeah.
Yes.
That happens because of it, because of the lateral movement, because of the contralateral running of all these fibers. Now, similarly, the second order neuron will reaches the thalamus after a synapse. In the thalamus, again, a synapse happen, and the third order neuron reaches the cortex. Okay.
Yes.
So if I have any damage in the spinal cord, I will have the ipsilateral lesion for the proprioception, and I will have a contralateral lesion for the pain and temperature. Is that okay?
Yes. Yes.
Because the fibers running in the opposite direction and the fibers running in the same direction. Now comes my descending tract, that for the voluntary movement, it is start in the motor cortex. From the motor cortex, the fibers run in the posterior capsule. Okay. From the posterior capsule, they will reaches to my medulla, and in the medulla, the decussation happens. And please note, synapse doesn't happen. These are the first order neurons that decussates contralaterally, and now they will run in the contralateral spinal cord in the corticospinal tract, right?
Yes.
They will run in the corticospinal tract, and in the spinal cord, okay, in the anterior horn, the synapse happen, and then the lower motor neurons originate in the anterior horn, and it will supply these muscles. So whenever a lesion happened in the lower motor neuron, I will get the ipsilateral muscle damage. Whenever a lesion happens in my the corticospinal tract, I will get the ipsilateral muscle damage. Whenever a lesion happens before or above my medulla, that means any stroke, I will get the contralateral muscle damage. Is that okay?
Yeah.
That would be
Yeah.
everything on this page. Any doubt? Please ask. Finally, we have the cranial reflexes. The easy way to remember is to go from these number, the 1, 2, 3, 4, 5, 6, and 7, 8. You guys already know about the lower limb. We have discussed that. In the center, you have the 4, below that, and above that, right? Remember?
Yeah.
Yes.
So if I want to know about the Achilles tendon reflex, it is by the S1 and S2. If I want to cause a dorsiflexion, which nerve roots are involved?
L4, L5.
The L4 and L5,
L4, L5.
right? If I want to flex my knee, what nerve roots are involved?
L4, L5.
L4.
Yeah. Now, L4,
L-
L5, no. L5 and S1. Yeah, for the flexion, it will be L5, S1, S1, S2 for the Achilles. For the extension of my knee, it is L3, L4. For the dorsiflexion of my foot, it will be L4, L5, right?
Yeah. Right.
Now, for my for the flexion of my limbs, it will be C5, C6. For the extension of my limbs, it will be C7, C8. That means the triceps 7, 8, biceps 5, 6. Okay.
Yeah.
Am I audible to everyone?
Yes.
Yes.
Okay, now if you look for the anal region, okay, now see these are the S1 supplying the dermatomal, S2 supplying this area, S3 and S4 and S5 are the areas which are supplying your anal region, right? So the anal wing reflex is by the S3, S4 and S5, mainly S3 and S4. The cremasteric muscle reflexes, because if I go above the L4 and L2, L3 and L4, above that I will be having the L3 and L2 and then L1 and L2, right? So the
Yes.
cremasteric reflexes are supplied by the L3 and L2. Okay, and what nerve is responsible for the cremasteric reflex?
Genitofemoral nerve.
The genitofemoral nerve. Okay, so that's how you can learn all these reflexes. For the primitive reflex, they don't ask you much, just you need to know about the Moro reflex. Okay, it disappears after some time, and you need to remember, 2, 3 only. One is the palmar reflex, which is the Grass reflex. Okay. Second is the plantar reflex. Okay. And in the plantar reflex, you have the Babinski reflex. Whenever you have any damage in the frontal lobe, yeah, we can do that. We can stop at the reflexes and continue tomorrow. If everyone agree, okay.
Yeah.
Okay, so we
Yes.
will stop at the reflexes, okay, and then
Yes.
continue from the reflexes tomorrow.
Yes. Agree.
I hope you guys able to remember all these information, all these complexities.
Yes.
No, because all these fibers, running tracks,
Yeah.
yeah,
It's
it
too
is very hard to
complicated.
yeah, it is too complicated. But if you know, if you remember them, if you just what I can say, revise them again and again. Okay, like
Yeah.
4 or 5 steps later, you will be able to know all these pathways, all these tracks, all these nerves.
Yeah.
Just try to visualize in your mind the picture, draw a picture in your mind, and then learn all these things with a picture in your mind. That will help
Okay.
you.
Okay.
Because ultimately, ultimately in the exams, you need to identify all the CTs and MRIs, right?
Okay.
So, all the best for that.
Thank you. Thank you for.
It's
Thank you
great
so
that
much.
we have your videos so that we can revise and again do that. Thank you.
Thank you.
Thank you, everyone.